My name is Hermes Fernandez. I am chair of the Health Law section of the State Bar Association, and I am co-chair of Schoeneck King's Health Law practice. Following me will be Teresa Rusnick, who is a member of our Labor and Employment Group. Following Teresa will be Dr. Ann Regina Falsey, a physician at the University of Rochester, a infectious disease doctor, and finally Monica Barrett from our New York City office, who is a member of our higher education group. We are moving quickly regarding coronavirus, not as quickly as our technology. Apparently our technology is not as quick as the coronavirus, but things are moving very, very quickly. At least for me, some of the things I'm going to talk about will not be reflected in the slides that you will see, because things have happened since I completed these slides. I completed the slides on Sunday, and there's been several significant developments that we will have to discuss as well. One is that the state legislature passed a bill last night giving the governor and commissioner of health new powers, new authorities, and the governor and the commissioner of health already had extensive authorities to deal with communicable diseases and newly emerging diseases. Those authorities have been enhanced. The other thing that has happened, and this happened mostly yesterday, began to happen on Sunday evening, is that the Federal Center for Disease Control began to authorize testing for the coronavirus by other than the Center for Disease Control. The United States really was lagging in testing. There had only been something like 300 tests given throughout the entire country in terms of who might have been exposed to the coronavirus. By expanding testing, and now New York State is authorized to do its own testing through the Wadsworth labs here in Albany, which is really a first-rate medical facility, medical center for testing and for research. New York City Department of Health is looking to begin doing testing now today. Apparently 700 entities have now been approved to begin doing testing. That's a game changer because the numbers may change overnight. We may learn essentially that this emerging disease in the United States is much larger than we had thought, because there simply were not tests being done. Now there may be tests being done. I'll be talking about some of those things today. I'll talk some about why people will be tested, who might be tested, how this will roll out. But those are two extremely significant changes in the last 2 days, really in the last few hours. The new law that I mentioned was not even a bill at 7 o'clock last night. It was being debated last night. There was negotiations on what the bill would be. It was passed sometime after 9 o'clock. I got to read it this morning at 7:30 when it became available. So with that, there's other things that we really need to look at in terms of what this means, what this whole discussion will be from a public health perspective, right? And the public health perspective is what's going to imbue all the discussions that we have, whether it's discussions about what you do with your employees, whether it's discussions about what happens at the schools your children go to, the colleges and universities people may go to, what's going to happen with your own family in terms of these things. I'm going to stay in my lane. I'm not going to talk about the medicine, right? We have a physician in the program who will do that. But the issue of the disease itself and what the public health authorities is going to be my topic today. So when we're looking at this, we're also looking at pretty well-established authorities, despite the fact that, at least in New York State, we're talking about a new law passed yesterday, which I expect the governor to sign today. But we're also talking about, to a certain extent, really going old school. And by old school, I mean medieval, right? We're talking about a disease that at this point has no treatment, no vaccine, no cure. Right? So what does that bring us back to, right? That brings us back before the days. It's a virus, so I realize we're talking about a virus and not a bacterial-based disease, but we're talking about something before there were antibiotics, right? Before there were sulfa drugs, right? We're talking about old school issues of how to deal with a disease that is spreading that's dangerous, right? And that has...
Sorry, I missed that. Could you say?
No, Siri wanted to follow along. And we're talking about something that's dangerous, and that what may occur, we have to rely on old methods, right? So some of these old methods are actually, been modernized to a great extent, and some of them are still just old methods. Once upon a time, back in the days of Disney movies, and even before that, right, we were talking about ships coming to port, right, in a disease circumstance, right, and cities would refuse to allow the ships. Well, they may dock, right, but they wouldn't allow people off the ships. We've actually seen that very recently, right? We saw with the cruise ship, right, where people had been to Japan, been to China, right, and they maintained on the cruise ship. There was another cruise ship in the Pacific Ocean that was trying to find a port that would admit, right, because they were going from port to port, because people on that ship had been to a city where there had been disease, right? The Italians did that, in the late Renaissance, and the ports of Venice and things in the northern Italian cities. They would close their gates, right? The gates go up. You've got the moat. You've got the walled cities, right? They keep people out. Right? That's actually happening in Italy right now. Cities in Italy are refusing. Provinces in Italy are refusing to allow people to come in who've been in other provinces in Italy. Right? We've got a different system in the United States. You can't do that in the United States, but those types of things are going on right now.
Hermes, could you
close down a whole city? They closed down the city of Wuhan, which maybe I'm not.
Hermes, can you get a little closer to that microphone or speak up a little bit?
A city of many millions of people. Right? That city was closed down. Now China's doing something different. China has actually, you may have heard of Alibaba, right, which is the Chinese Apple. Right? They've put together something called the Ali app, and China is requiring people to download the app on their phone, and then they're tracking their population, and they're putting on people's phones red, green, and yellow. Right? We know what red, green, and yellow all mean, right? Stop, go, and caution. So you go to enter a place in China as this is being developed, you have to show your phone. The phone says to the security people, red, don't let this person in, green, they can come in, yellow, follow them, right? That type of thing is happening. So they've gone, right, they're taking old methods and using a very new technology to go with those old methods. So before I come actually to any of the slides, I'm going to finish this introduction. In our country, we may see quarantine, we may see isolation. We also will see tracking and reporting and education, right? We've seen quarantines recently, right? If you just think back in the last couple of years, there's been measles outbreaks, right? There have been people who refuse to get their children vaccinated for measles, right? And that very effective public health method of vaccination, right, doesn't work unless you have a very high level of participation. Right? And because in certain areas of the country that level of participation was dropping, right? Schools were closed, right? Children were refused admittance to schools, right? And there were circumstances of required quarantine, right? Required closings, right? And we saw even in New York where there was a lot of effort last year legislatively to narrow the religious exemption for vaccines, and that was right to increase the efficacy. And children were being refused admissions to school. At the beginning of this school year, right, children in New York State were being refused admission to school who had not had vaccinations. Those types of things, if you think about what you've already heard, you actually know a lot of what's coming, because those are the circumstances that we will be facing with this disease. So let's go to the next slide, or the first slide. Okay, let's skip that one. We know who I am. So we have, in our country at least, we've got a division of authority, right? Think back to your days in school, right? We have a federal system, right? The federal system actually is meaningful. There's the federal government, there's New York State government, New York State has local governments. And I've highlighted here school districts because school, right, we have mandatory public education. Schools actually play a great role in this sort of public health issue. New York state government relies heavily on local government. Local governments are, from the legal perspective, they are actually arms of the state. And so the state authorizes them to do certain things. Local governments will play a huge role in this in terms of tracking and reporting and probably making decisions as to whether people will be asked to isolate themselves and if we go further. Next slide, please. Actually, I've covered some of this already in my introduction. What's happened overseas? I mentioned China, Italy, Japan. Right? Japan, where the Olympics are supposed to be taking place in the next couple of months. Japan's in a panic about getting those Olympics done. Right? So what's Japan done? Japan has closed schools for a month because, as any of us know, who've had children or grandchildren, right? Those little folks, right? They carry disease, right? The schools are means of transmission. So Japan has closed schools for a month, hoping that things will improve. They can get the Olympics off. They're refusing to allow crowds, audiences for their spring training baseball games at this point. And that's something we've actually seen in the United States too. I remember just literally 30 years ago, there was in the Albany area, there was a measles outbreak. So measles once again. And the State Department of Health at that time was coming to the end, it was about this time of year, it was coming to the end of the high school basketball season, and the basketball playoffs are beginning. The health department allowed the basketball games to be played. They wouldn't allow any spectators. So in the Albany area, games were played. They were played in empty gyms with coaches, referees, players, and that's it. It would have looked like a CYO game, except there were no parents as well. So we've got these things happening. Next slide, please.
Hey, Hermes.
Next slide.
Hermes, we're having a little trouble hearing down here. Could you stand a little closer to the microphone?
I cannot.
Can you have somebody turn up the volume maybe then? We got to get a little better volume. Thank you.
I'm as close as I can get to the microphone.
Well, maybe talk a little louder then.
I'll try to talk a little bit louder. Okay, so other events overseas. France, the Louvre is closed. Right. France has banned indoor crowds of more than 5,000 people. That's a very rough marker, but France has done that. Cruise ships, I've already mentioned. Let's go to the next slide. So here, in our country, as we go back to our federal system, the federal response, the federal government is going to set the standards for what can and can't happen. But the federal government is not going to be in the implementation business, except at our borders, right? The federal government has control of our international borders. The federal government, and we've already seen that. There's an executive order that Donald Trump, as president, signed at the beginning of February, banning Chinese immigrants, banning Chinese tourists who come from certain areas. It's been extended to Iran. There's some discussion now about what will happen with Italy. But there are rules. So you've heard about people coming into the country being told they have to be essentially self-isolated for 14 days before they can come in. That's all due to the federal standard. But beyond that, beyond the control of our borders, the federal government sets standards for public health, right? But they're largely advisory. Some of them are mandatory, some are advisory. They will set standards in terms of who should be tested. They will set standards for how testing should be done. They will set standards for issues regarding quarantine and isolation. And they will provide funding, because funding is going to be very important in all of this. They also, and this is an area where they go beyond standards to actually legal rules, it's the federal government, right, that approves drugs, approves medications. Food and Drug Administration does that, right? There's we've heard some discussions about things like vaccines, right? Vaccines are probably 12 to 18 months away because it's not just a matter of inventing the vaccine or inventing a drug. Things have to be tested. They're tested for efficacy. They're tested for safety, right? That takes time, right? You test first. They really run things theoretically. They test on animals. You get past a certain point, you test on humans. You get past a certain point, you can test on more humans, and then you move out there, right? It's actually a 4-step process to get through the FDA system. They approve drug treatment regimens. They approve the testing kits. They approve the tests. So as I mentioned earlier, the testing process that is now being allowed to go on. They've expanded that. They will test the testers, but that expansion has occurred. Next slide. My slides, mine's a little ahead of my slides here. So we've already talked about the control of the borders and the executive orders. Let's go to the next slide. Okay. Now, the principal agencies of the federal government, the Food and Drug Administration, they're the ones who are going to be doing the testing. Center for Disease Control is going to coordinate tracking. They're the ones that people are going to be looking to for information. You've seen, most of the doctors you've seen on the news coming out of the federal government have been CDC doctors. Right? The National Institute of Health, I'm not going to linger on that, but the National Institute of Health plays a huge role in these things as well because the National Institute of Health does a lot of research. A lot of the funding for researchers goes from the National Institute of Health. So they are very important when we're talking about emergent diseases. Next slide. New York State. The way our system works, the state government is the most important level of the public health response because the state government, and here it's primarily the State Department of Health, but also the State Education Department is playing a big role in this. The Office of Children and Families is playing a role. There's a lot of different state agencies involved. They are now, at the state level, taking that guidance from the federal system. The state turns that actually into law and into regulations, saying what can and can't be done and who can do it. So it's the state government that is working through local boards of health, dealing with reporting and coordination requirements. The state government does licensing of hospitals, healthcare providers, right? The Education Department licenses physicians, nurses, allied health professionals. The state of New York licenses hospitals. So every hospital in the state right now, every nursing home in the state right now, all kinds of healthcare providers, community healthcare centers, are all busy putting together protocols for how to deal with this virus. Now, they are probably farther ahead or further ahead than most everybody else that you can think of, because most of the protocols that will be put in place will look very much like protocols that are already in place for things like the flu, right? And so they know what they're doing, right? They know how to do it. You can take comfort in that process. They know what they are doing. Can't hear me again?
No, they asked if you can actually talk closer into the microphone.
Am I supposed to shrink?
I don't know. I spoke to Alan in IT, and Alan said there's nothing that we can do on our end. So I guess it's been a clear question.
All right. All right. We're going from the sublime to the ridiculous here. I am going to lean down, crouch over, and we'll see how this works. Is this better? Can somebody give me a wave or a signal elsewhere?
It's better. Better.
Good. All right.
Would you like a stool or a seat?
I don't know. Apparently, our speakers are now limited to 5 foot tall. All right. So, here we are. So the reporting requirements regarding the hospitals and healthcare providers, right? They have, as I said, they've already got in place really what they need to do. They're in the business of tweaking at this point. They're right now looking at, okay, what do we do with the coronavirus? I've got some slides in here. In fact, as I said, things are moving quickly. There are literally flow charts that the healthcare providers have. And these flow charts say, you know, someone presents, right? Where is the person? Have they been in China? Have they been in Milan, Italy? Right? Okay. Yes. Have they been present with someone who has been exposed? So let's say we have someone visiting back from, who's just flown back from Seattle to New York at this point, and they happen to work at the nursing home in Seattle, where we've seen now a cluster of individuals who were exposed, right, and a cluster of deaths. That would be the first, there's your first criteria. Then they say, okay, does the person show any symptoms? Do they show any signs? Oh, they have a cough. All right, now let's take a look at that. And they go through this entire flow chart. So every time you get a no, you kick the person out of the system. They get a yes, they continue to do the testing. Once, if you get the yes, you get the positives, then the next question will be, what do? Do you isolate, go from there? But those things are all there. So now New York State also has what I'm calling coercive authorities, right? And they are coercive. Right? You can be requested to isolate, right? That's the kind of thing like, it's a suggestion. It's a suggestion with force behind it. Because if you refuse to isolate, you can be compelled to isolate. There's actually a distinction between isolation and quarantine, but for common purposes, they are really the same thing, right? One way or the other, you're either talking about individuals or groups of people. Typically, quarantine is groups of people, or isolation is individuals, but it all has the same effect. And the health department can order closings. I mentioned in the past, the health department has done that. We're seeing that overseas. I expect to see that in the United States. Next slide. Okay. So how does the health department do its work? Right? It supervises local boards of health. New York City has a board of health. The New York City Board of Health is, to a great extent, independent of the the State Department of Health, but they work closely together. I've put, and you'll see later, resources that you can take a look at to see things. So I've got the the CDC's website available to you, the State Department of Health's website. I didn't list the New York City Bureau of Health, but you might want to take a look at that one too. They've got excellent information. In fact, all three of these have excellent information. Yeah, go ahead.
You mentioned that the local governments are going to play a big role. So should we be on like the county websites and that type of thing? Where?
Yeah, I'll come back to that, but absolutely.
Okay.
Absolutely, that's what. So I'm going to direct all of you. If you have questions, you can call anybody in our firm. But the boards of health are going to play big roles here. The New York City Department of Health has really excellent information on their site at this point. In fact, as I mentioned, all three of these folks have great information, and it's largely very understandable. So it's very helpful. So the State Department of Health, working closely with the local boards of health, are setting up the rules, talking about how do you do tracking, so who do you report on, right? And there's a well-developed reporting system that you may not be aware of, but it's existed, it has been in existence, that's what's being used, it's really simply being tweaked. It comes up in all kinds of ways. And some of these things are pretty remarkable, and you've heard of these before. For example, things like food poisoning cases. The public health authorities are all over those things. It's remarkable, right? When you see something like a food poisoning relating to bean sprouts, and they trace the bean sprouts back to a farm in California, right? And that's because of the physician's report, the nurse's report, all the healthcare providers along the way report. They do these trackings. It's exactly the same thing for this. It's going to be that sort of process. They also promote education, and you'll see quite a bit. I saw last night, around 11 o'clock, I saw the Commissioner of Health on a commercial talking about what to do in these circumstances. There's a lot of that. There's a lot of that on these websites as well. What to do, right? The big thing, wash your hands, right? Wash your hands, right? That's the biggest piece. Cough into your elbow, all those kinds of things. And stay home, right? Stay home. If you want to be a hero in this outbreak, the thing to do is to do what you don't always do. You stay home. Promoting education and the prevention of diseases. And the health department promotes and provides diagnostic and therapeutic services for communicable diseases. Let me go to the next slide. The health department's authorities, I've listed some of them here because they simply illuminate the issues for us. But the health department supervises camps, hotels, public eating and drinking establishments, right? Bars and restaurants, right? Places where people gather. And these are loaded words. You know, I had a first-year law school professor who would call certain words weasel words because they had so much behind them. Supervising and regulating the sanitary aspects means if the health department, and this is handled at the local level, they're the boards of health, if they don't like what's going on, right? So this isn't a matter of just testing putting a meat thermometer in the food. It's not a matter of just looking whether the dishes are getting cleaned or whether the floor is being swept or even rodent infestations, right? This is a question. If they think that disease is being spread, communicable diseases are being spread through any of these sorts of establishments, right? They've got the authority not only to tell them what to do, but to tell them, probably a good time for you to take a vacation, shut them down, right? The boards of health have that kind of authority, and in this kind of circumstance, we may see these things being used. They also do things like require testing of healthcare workers for communicable diseases. If you were a healthcare worker and it's flu season, you've got to get a vaccine. If you don't, you may not be allowed to go to work. There's some exceptions to that in certain issues, but those kinds of things now are going to come up. Next slide, please. This is more of an inside piece than anything else, but there's an entity called the New York State Health and Health Planning Council. It's a powerful entity. It works closely with the State Department of Health. Regulations that the State Department of Health put out, if they deal with certain issues, and communicable diseases is one of those issues, the State Health and Health Planning Council actually has to adopt the regulations. The Health Department becomes the staff for this council. The council is made up of people throughout the state. There's some lawyers, there's healthcare providers, there's hospital executives, there's a host of different people, there's physicians on this. They have authority over the New York State Sanitary Code. The New York State Sanitary Code is where the rubber hits the road on a lot of these issues. The State Sanitary Code deals with communicable diseases. It deals with public pools. It deals with really anything, right? It deals with clean water. It's the core issues of public health, right? Sewage, those kinds of things, all in the State Sanitary Code. And communicable diseases are a big part of it. Next slide, please. The communicable diseases are literally set out in the regulations. Next slide, please. And communicable diseases means infectious, contagious, and there's a third. Actually, go back to the previous slide. Infectious, contagious, or communicable. So there's a little bit of circular reasoning there. But infectious and contagious have words that have different meanings, right? Typically, one is something you need much more contact on, right? There's actually real interaction where something that's contagious or communicable is more likely to be spread in the air or through what's lingering on tabletops, for example. That's why if you take a look at the websites, you'll see directions about how often you should be cleaning things and what occurs. Okay, next slide, please. There's actually 64 communicable diseases. It's actually next slide, because the 65th has been added, and that is the coronavirus. Actually, not even the coronavirus, because the coronavirus, I don't want to get too far out of my lane on this. Basic coronavirus is a common cold. This is actually being called novel coronavirus, and then it's called the disease is COVID-19. Novel being just being seen, right? So it's just being reported. So Communicable disease is also, or any disease outbreak or unusual disease must be reported to the State Department of Health. So when healthcare providers see something they haven't seen before, they're required to let the Department of Health know that. And this, if COVID-19 were not now on the list, it would still fall within the list because it is an unusual disease, right? It's newly apparent, it's an emerging disease. And there's reason to believe it can be caused by a transmissible infectious agent, right? That transmissible infectious agent is the virus itself that people may cough out or sneeze out, whatever. Next slide, please. We can go through these. This is just for you to show you the breadth of communicable diseases. Go through the next 3 slides, please. And then we finally, COVID-19 was added to the list on February 1st. Let's go on from there. So I'm kind of repeating myself here, but the keys and the structure of communicable disease, the way the health departments and its local agents, the boards of health work, right? Reporting, tracking, care, education, isolation. Those all have real meaning. They are literally the keys to how the public health authorities believe they can limit the scope of problems created by emergent diseases. So reporting means somebody's seen something, right? Now they're identifying it, they're saying this is real. Tracking is what's going to happen to many of us. Because when people are revealed to now been exposed to the disease, we're all going into the system. It's going to be reporting about, I saw 50-year-old white male presented with these, right? And that works its way through the system, right? I saw a 4-year-old child who reports through the system. The care piece, right? That is where the guidance is coming from the public health authorities. The education is two levels. It goes to the healthcare professionals, and the education goes to the public. How to protect yourself. And then isolation is something that seems benign, but wait till we live through it, because right, it's not going to be that easy to do. And again, it's a very broad scope of authority. There's ability to say the public health authorities have gone too far, but courts are going to be very deferential to the role of experts. So if you think it's unfair what's happening to you, maybe we'll see some circumstances, but we are going to see a very, very deferential court system through this process. Next slide, please. I want to highlight here the development of protocols. The usual course, right, is education protocols, tracking and reporting, and stops there. Right? That's the usual course. The flu outbreaks, right, which happen every year, which we take for granted, right? People are urged to get flu shots, right? People are still being urged to get flu shots, even though it's now March 3rd. The reason they're urging you to get flu shots now, while the flu shot this year was only 40 to 50% effective, is because at this point, not only is there still hope that you may not get sick, but at this point, given the concerns for COVID-19, the public health authorities want to keep hospital beds free. And so they're urging people to get flu shots as essentially a backup plan to say, let's keep our ability to deal with what may be coming down the pike, which we still know very well, right? At this point, there's worldwide 90,000 identified cases of COVID-19 and 3,000 deaths, which is a mortality rate of over 3%. The flu, my understanding is, again, I'm leaving my lane a little bit here, my understanding on the flu is the mortality rate is 1/100 of 1%. Right? And so we've got lots and lots of flu cases every year. We all kind of just expect it, hope we don't get the flu, and kind of shrug. But literally millions and millions of people get the flu every year, and we've got, I think, so far this year, 40,000 deaths from the flu. Kind of just accept that, right? Take it for granted that that will occur, and say, well, it's mostly elderly people, it's mostly people with comorbidities, and we're hearing a lot of that with this disease as well. But all of those pieces, they're still saying, let's try and get away from that so we can at least get this, let's get this handled. Next slide, please. There are designated reporters. I don't believe any of you will fall into that category, but the reports go to local boards of health, they go to the health department, right? Full name, age, address, what the disease is within 24 hours, right? And that's going to that ties into the rest of these pieces. Next slide, please. Next slide. I'm going to come back to this slide. Let's go ahead and go to the next slide. Yeah. Now, there's authorities that this is taken so seriously that if a physician isn't in attendance, the duty to report actually comes to, and this is a quote, the head of a private household. This is right. People don't usually do this, but the law actually says the head of a private household has a duty to report when there's a communicable disease. Good luck figuring out who's the head of your household, but apart from that issue, this goes to others as well. The school, right? So school principals, hotels, camps, vessels, right? These things, it goes on and on in terms of this. So this reporting requirement is very, it's meant to be real and meant to be not, I would say, expansive. It's meant to be inclusive, right? It's meant to be everybody. Next slide, please. Now, here's what the kicker in this that I've been talking about, and I think where people are really looking at what may occur, right? Every local board of health and every health officer, so these are going to be local officials. Not every county in New York State actually has a board of health, but every place in the state has somebody who has these authorities. They may provide for care and isolation of a communicable disease in a hospital or elsewhere when necessary for the protection of public health. So, the local board of health, right, can require somebody to stay home. They can require somebody to be placed in the hospital. Right? These things, this doesn't happen often, but we've had it occur in other circumstances. When I was first involved in state government, we had the crack epidemic, right, in the late 80s. And during the crack epidemic, one of the other things that developed was there was outbreaks of tuberculosis in New York City. Kind of something you kind of think in the ancient past, maybe for some of you that the late 80s is the ancient past, but there was a tuberculosis outbreak. And there were people who, the state would say, you have to get treatment. And tuberculosis is actually a very prescribed regimen for your treatment. And it has to occur in an inpatient setting, and it takes a certain period of time. And there were people who refused. But they all got that treatment, because if they refused, they were literally, there were court orders, they were brought to hospitals, they were put in tuberculosis isolation, and they were required to go through the course of treatment. So these things were not widespread, but they occur. And so, and now we may see this in a widespread area. The next bullet point: the local board of health. Stay on that slide. On that slide still. Prohibit and prevent all intercourse with the use of the infected premises, place, and things, and require, if necessary, the means for thorough purification and cleansing of the same. Right? So you can be told you have to stay at home. You can be told, right? And the course here, we've seen it with people coming back from the cruise ships, for example, in 14 days. That's why I brought up the 14 days. That at this point is thought to be the incubation period. It may turn out to be different. We really don't know they don't know at this point who is actually contagious. You might be contagious even though you're asymptomatic. But you can be prevented from all intercourse, right? So that's not just being told to stay home, but just like don't visit, right? Don't just not come to work. They can check on your home. They can then tell you, you got to clean the place, you got to fix it up. And that's actually, for which I'm not going to talk about except this one reference, for healthcare professionals or healthcare providers, they actually have a full regimen of what they're supposed to do, where they see someone about cleaning the rooms, about air exchanges. There's a lot of different pieces that go on for in terms of healthcare providers and things like that. But this actually could be enforced against individuals as well. I wouldn't expect this piece to happen, but it's there, and we'll see the full scope of this issue. Next slide, please. There is literally a right of entrance and inspection. Right? If things are serious enough, local Board of Health can inspect and control all persons and things. Right? So examine you. We're seeing that, I mentioned with the app in China, and you've seen it in China. If you've seen any news, we've seen people literally being stopped on the streets and running kilometers over their heads. I'm not saying that's what's going to happen here. We'd expect it. We don't have that sort of system in the United States. But on individual bases, these things can occur. Next slide, please. If there's an order of quarantine or isolation, a sign to be posted. A sign to be posted at the place of for isolation and quarantine, and nobody can take that sign down until the public health authorities say the sign comes down. You can't cover it, you can't block it. Right? This is not the way we think now. We think, right? We live in a world where everybody thinks about their privacy, and there's no privacy on the internet. We've all exposed ourselves, but we still kind of think about it at our home, at our place. People will leave us alone, allow us to do what we need to do. If there's quarantine or isolation, signs will go up. And I'm not saying they have to go up, but they have these authorities to do that. Next slide. Next slide, please. This next one talks about this is closer to the reporting requirement than it is to the actual isolation requirements. But a physician actually has the authority. And it's a very brief authority, but a physician actually has the authority to say, you know what, you need to be isolated. Now, right, typically the doctor will say, stay home, don't go to work, don't send your child to school. But the physician can put some force behind that. And we'll see in terms, we haven't seen this yet in the protocols, and I've been reading a lot of the protocols in the last few days. I haven't seen any protocols where the health department is telling physicians to do this. But this is still in the bag of authorities. Next slide, please. This again, I'll skip past this when I'm running late. These provisions, this is more of the coercive authority. Let's go to the next slide. And that last slide is about more authority, you can't do it. If you refuse, and this doesn't seem like much of a penalty, right? There's a fine of up to $250 and up to 15 days in jail. So just let's balance the individual risks. If you're being told to isolate for 14 days, better to isolate for 14 days than do 15 days in jail, right? And then have to pay the $250 for it. But these are real, right? These are real. Next slide, please. There can be court orders, and you can be committed to a hospital or institution, which I mentioned in the tuberculosis circumstances. That's literally what happened. People were committed to hospitals and institutions. Just as an aside, and hopefully our physician presenting a little later will talk about this, but one of the things that the protocols are telling people now is if you feel sick, let's step back, let's do things. Don't go where other people are. It's still being sorted out where you will go for testing and treatment, but actually it could turn out like the worst places to go may be hospitals, because that could cause clustering, that could cause more exposure. But those things are still being developed. At this point in our state, we still only have 2 identified cases. Next slide, please. I've already talked about this, the distinction between isolation and quarantine, but for all practical purposes, it's not going to make a difference to you if you're isolated or quarantined. Next slide, please. There's something called personal quarantine as well. The personal quarantine is where you are restricted to certain household contacts, or incidental contacts. So it's a little bit broader. That may be what's more often used here. We'll see as these protocols are developed. Next slide. I've already talked about this, but in terms of the isolation and quarantine, one of the things that's most alarming in these old authorities, and this may be something that we're going to see challenged, I didn't expect it to be challenged, it's actually ordered. But not only can you be told to clean, right? Not only can you be told to disinfect, but in certain circumstances, and I would not expect that in these circumstances, unless the plague comes back, I'm expecting this one to be rolled out. But the public health authorities actually have the authority to order the destruction of premises. So that's a pretty severe authority out there. Next slide, please. Now, the governor emergency powers. This slide predates what I told you in the law that just changed. Some of it, but most of it remains the same. The governor can declare an emergency due to an epidemic. The emergency can last for 30 days. The governor can suspend state laws and regulations specifically related to the emergency. What we're talking about is, and this law was just last night, the governor was given further power in this. What you're talking about in those circumstances is rule by decree. Rule by decree is dictatorial powers. The legislature will have the authority to overturn them. The legislature can countermand the governor's order in these emergency circumstances by concurrent joint resolution. That means both houses of the legislature can take a vote, and the governor it's not up to the governor signing or vetoing that joint resolution. So the legislature can step up and say, "Governor, you've gone too far." Frankly, it's hard to think, after all the powers I just told you about, what further powers could be possibly required. But the governor, and this has long been in the law, the governor's had these emergency authorities. The statute, there's not yet a statute, as far as I know, the governor hasn't signed one while we're talking. But this emergency, going beyond COVID-19, is also going to cover fires, floods, earthquakes, hurricanes, tornadoes, high water, landslide, mudslide, windstorm, wave action. Those are all related to climate change. So the legislature yesterday gave the governor emergency power to the Climate Change Action Act. So again, for 30 days. So it's very, very significant. You can see the seriousness with which the governor and the legislature and public health authorities are regarding this outbreak. It's such an extreme authority that doesn't align at all with democratic values. It's been really great to the governor. Next slide, please. The school districts. School districts, and I think you'll hear more about this from other speakers, but school districts play a really important role in the spread of disease, right? We've got free public education, there's compulsory education. There's various things that school districts may do. But one of the things they can do is they can close schools. And they can exclude students. I mentioned that in the case of measles. But the other thing that they are required to do, just like those reporting requirements I talked about, they are central to the reporting requirements, to the reporting and tracking of disease. So whenever a student shows symptoms of a communicable or infectious disease, reportable under the public health law, right? So that's students got a communicable disease. That student can be excluded from school. And then the school district has reporting requirements that go all the way up. And the state education department has put out protocols to school districts already. They've put out guidance. They've done joint proposals, not proposals. They've given joint directives between them and the Department of Health to school districts. This language is very significant because this means you can't simply say, "Gee, I'm worried about where that child is." The child can be kept out of school, but the child has to show symptoms. And frankly, I'll tell you, just the questions we've gotten from clients over the last few days, there's been a couple of things that have alarmed me because in terms of folks' reactions, we've got some questions that suggest people are taking a look and saying, "Oh, there may be a COVID-19 issue here, so we don't want this student coming to school." No, the child has to show symptoms of communicable disease, and that's going to be a little problematic because, so far, the reporting has been that you can be contagious and asymptomatic. So, who do you keep out, and how do you decide who to keep out? That may lead to actually more likely to the prospect of school closings. And think what happens in school closings, right? School closings means parents stay home, means people don't go to work. I mean, you're going to be dealing with how to deal with this. This will be talked about by the next speaker. But you see just the domino effect, right? That's how these, right? That's ways that the economy is going to slow down. That's ways where you're going to have to deal with issues of, what do you do with your employees? How liberal will you be with your employees? There's going to be sick leave issues, there's going to be FMLA issues, all because of, I think, really stemming from this authority as much as from anything else that we've spoken about. And there's, you'll see if you go on the state education website, if you go in the health department's website, I just saw something very good from the National School Boards Association yesterday, suggesting things that schools should be thinking about. But those are actually, a lot of the things they suggest are actually things that you should be thinking about for your own workplace in terms of how do you deal with your students and your employees, what accommodations you're going to make, how are you going to pay people, how are you going to encourage people, especially if you have people who don't have paid sick leave, what's going to happen in those circumstances. These things are all going to be one tied to the next. Okay, next slide, please. I've covered almost all of this. The one thing I want to highlight here regarding local departments of health is New York City's rules sometimes, but not always, don't line up with the state rules. But they almost always do. The city of New York has a very capable Department of Health. Again, their website is excellent as well. Next slide. Okay. These are resources. There's others as well. I put the Office of Children and Family Services up among the resources because they deal with children in various circumstances that can be significantly important to all of us. And so they've put out some useful information as well. So take a look at those things. And the Center for Disease Control, next slide, I've got some federal resources here. Local departments of health are listed, and then the Center for Disease Control. So we got off to a little bit of a late start. I apologize for the confusion. I apologize for having to do the rest of this presentation in a crouching position. One thing that I want to bring to, if I will leave you with one thing, it's this. If you have questions regarding the health issues, right, and I mean just the health issues, but the local boards of health are there. They're used to getting these types of questions. They know what they're doing. I should say that completely, because I saw something from a local department of health yesterday that concerned me. But they know what they're doing. They've already got well-developed protocols. As again, the protocols can be tweaked from flu season to COVID-19, because that is really the parallel here. Use them as a resource. They want to be used as resources. They may feel overwhelmed for a while. I'm sure they will. But they're there. They're available to you, and use them. for your own, for your own homes, for your and for your workplaces, what you have to do with all of these various things is plan. Think about what you're going to do and how you're going to do it. You've probably already got various pieces in place. And so again, it's going to be a matter of aligning to what we have, to what we know. The last thing is, this is something to be taken seriously. Again, I don't want to get too far into my lane in terms of the medicine. It's to be taken seriously, but it is not to be taken overwhelmingly. Right? The public health authorities are trying to get out ahead of this. That's why we're seeing so much early, so that it can be managed, it can be limited. We've had some experience with other emergent diseases like this in the last few years. 15 years ago, 16 years ago, there was SARS, which was like this, an emergent disease. It presented in many of the same ways. It actually was more dangerous and a higher mortality rate. That was successfully limited, right? And it went away fairly quickly. We also had MERS. MERS, again, was also a higher mortality rate than this. Public health authorities were able to successfully limit it. It went away fairly quickly, right? Both those things may still be lingering out. I'm not saying they're not, but they are not common public health threats at this point. And the goal here on this one is to have the same thing occur, to get far enough in front of it to essentially, to surround it and to limit it, because epidemics can be self-limiting, and they're looking to make this with a push self-limiting. So thank you very much. I apologize for the rough start. I hope this was helpful to you. And our next speaker is Teresa Rusnick. She'll be speaking from Rochester, and hopefully we'll hear her.
All right. I'm hoping everyone can hear me, and I'm hoping someone will tell me in the other offices if they can't, but I know the people in front of me will be able to hear me at least. So, for those of you that don't know me, I'm Teresa Rusnick. I'm a labor and employment attorney. I do work out of the Rochester office, but today I'm in Syracuse so that more offices were able to have a live speaker. I am going to be talking about, oh yeah, there it is. Okay, great. So I'm going to be talking about how you deal with the coronavirus at work. While Hermes was talking in the last couple minutes, where he was going over the public health authority things, I pulled up CNN on my phone, and the entire first page was all about the coronavirus. So this is definitely something that's going to impact your ability to have employees in the workplace and have other people in the workplace too, because anyone can bring it in, vendors, clients, third parties, doesn't matter who it is. So the question is, what do you do about it? So this is our agenda for this morning, at least for my portion of this morning. So we're going to start by talking about affected employees. Those are people that are sick or could be sick, are potentially affected employees, people who have been around people who are sick, people who have traveled to countries where the virus is more prevalent. We'll talk about medical screenings and its flip side, which is employee privacy, how both of those things work and how employee privacy needs to be protected to the extent it can be. We'll talk about OSHA. Not surprisingly, OSHA has things to say about this. We'll go over it more when we get there, but OSHA has already released a page on how to handle the spread of coronavirus, including coronavirus in the workplace. We'll talk about preventing discrimination. This should not be news to any of you, but you can't discriminate against disabled employees or employees who might be viewed as potentially disabled. Another interesting hook that we see, particularly with coronavirus, although I think this may go away now that the virus is in so many countries, but we did see an element of discrimination against people who were Asian or who appeared to be Asian. We'll talk about some practical tips, things you can do in your workplace right now, things you can do in your workplace if someone should become infected or potentially exposed, and then we'll talk about a couple of case studies that I came up with, and we'll see if by the end we can answer them. So affected employees, we're going to start off by people who might be sick. So 2 laws protect employees with disabilities in the workplace. We have the Federal Americans with Disabilities Act, and we have the New York State Human Rights Law. Both prohibit disability discrimination, and equally as important, both require reasonable accommodations for employees with disabilities. So, is a contagious disease such as coronavirus a disability? It can be. It can cause an individual to be unavailable for work, and it may subject them to the need for reasonable accommodation in the workplace. So, you'll see in here, I know we're talking about coronavirus today, But as I was doing this presentation, it occurred to me that a lot of this could be applicable to any type of communicable disease. So I'll be using those two terms kind of interchangeably here, but please note throughout that not every disease is going to be treated exactly the same way. So in order to be protected by the ADA or the New York State Human Rights Law and to be subject to a reasonable accommodation, a person has to be qualified to perform their job. So usually when we're talking about if someone's qualified, we're talking about whether they have the experience, they have the skill level, they have the ability to do the job. But the courts have actually looked at that term qualified and have said that if someone poses a direct threat to the health and safety of others, they're not actually qualified to do their job within the meaning of the laws. So the courts have done an interesting thing here, and instead of creating a new law or recommending that Congress or the state legislature do the same, they said, okay, we're going to say that if you pose a direct threat, you're no longer qualified to do your job, and you're going to lose the protection of the ADA and the New York State Human Rights Law. So to determine if a person with a contagious disease is a direct threat, courts have set up this test. These are the factors that a court will consider in evaluating whether you guys made the right decision by keeping someone home from work or not subjecting them to the provisions of the ADA or New York Human Rights Law. So these are the factors. They were outlined in a case first called, I think, Airplane by the Supreme Court. I think that's right, but they've been used since then. These are the factors. The first one considered is the nature of the risk, which courts translate to how the disease is transmitted. The second one is the duration of the risk, or how long is the carrier infectious, how long can the disease be spread. The severity of the risk, what's the potential harm to third parties, other employees, clients, vendors, third parties in the workplace, and the probabilities that the disease will be transmitted and cause varying degrees of harm. So obviously our last one is the most subjective factor there, because it's going to depend on how you view the disease, and certainly will vary greatly for different diseases. But I attempted to apply these factors to the coronavirus. Please know this came from me. This did not come from a court. We have not had any courts rule on this yet because it is so new. But if you're looking at the nature of the risk, and I think the doctor following me can probably help fill in some of these blanks better than I could, but coronavirus is transmitted through the air and through person-to-person contact. So, for example, if I was standing in here and I had coronavirus, you all would be at risk for getting coronavirus because you're in close proximity to me. The duration of the risk, the carrier is infectious for at least 2 weeks. That may be subject to change because I am hearing now that they think people are infectious before they're displaying symptoms, but I think that 2 weeks is from the time of first symptoms or the time that they know they're infectious. Severity of the risk, for most individuals, coronavirus is not fatal, and it doesn't require hospitalization, but of course for some people it does, especially people who are immunocompromised or who might be elderly or otherwise have weakened immune systems. And then the probabilities the disease will be transmitted, it remains unclear as medical knowledge develops. Certainly if you look at the nightly news or the minute-by-minute news that we have these days, it looks like it's spreading very quickly. And certainly that is a concern that I'm sure the public health authorities will be watching. So, assuming if you looked at all these things, you looked at these 4 factors and you said, okay, it is serious when someone has coronavirus, but we're not going to say it's necessarily a direct threat, or we're not sure if it's a direct threat. Then, if it's not a direct threat, or if it's maybe not a direct threat, we're still in the world of having to accommodate the person under the New York State law and under the federal law. So, does a reasonable accommodation exist? Assuming it's not a direct threat, a reasonable accommodation is something, a modification that allows an employee to perform the essential functions of his or her job without causing an undue hardship to the employer. An undue hardship is one where it causes undue financial and administrative burdens or requires a fundamental alteration of the nature of the services the employer offers. So, for coronavirus, for any contagious virus, what we're most likely going to be talking about for a reasonable accommodation is leave. Leave can be a form of reasonable accommodation. It very often is a type of reasonable accommodation. I've even heard people say things like the Americans with Disabilities Act is an inadvertent leave law because it doesn't explicitly promise leave in the way that FMLA or PFL would, but it ends up that people end up taking leave under the law as a form of a reasonable accommodation. So whether direct threat or not, you can place people on leave. You can place infected employees on leave. That reduces the risk to others, and it allows the employee to recover. That's probably the most important part from a disability standpoint. The leave allows them to recover. Leave may be paid or unpaid at the employer's discretion. Employees may also be able to use accrued paid time off. Most of your existing sick leave and other PTO policies probably already provide for this if you take a look at them. But leave does not have to be paid if a person is too ill to come to work. Okay, how long should the leave be? An employee should be placed on leave until they're free of the contagious disease. Employers can require documentation from medical professionals that the employee can return to work. They don't have to have it. You can choose to believe your employee and let your employee return to work, but you can always ask. Say someone's been out for 2 weeks with coronavirus. You can say, okay, I need a note from your doctor saying you can come back to work because I don't want you posing a risk to anyone else, and I want to make sure you can actually do your job when you get back. Depending on the illness, of course, this leave could be different periods of time, and depending on the person too, right? Some people may recover from corona very quickly, some people may take longer, some people may show virtually no symptoms, other people might be in the hospital. So it's always going to differ on a case-by-case basis. All right, so that's ADA and New York State human rights law. And I should have said this at the beginning. If anyone has questions, either here or in the remote offices, just interrupt me and I'll try to answer them. So FMLA, our Family and Medical Leave Act, that's another one people think of when they think of sick employees and whether those employees can take leave. So the test there would be, is a contagious disease a serious health condition eligible for leave under the Family and Medical Leave Act? The Family and Medical Leave Act, or FMLA, defines a serious health condition as an injury, illness, impairment, or other condition that involves inpatient care or continuing treatment by a healthcare provider. So if the contagious disease involves a hospital stay, then FMLA applies. FMLA provides a maximum of 12 weeks of unpaid leave. Please note for FMLA that an employee does have to qualify to take FMLA. There are some different work requirements, and the employer itself has to be a qualified FMLA employer, which is the at least 50 employees within the 75-mile radius test most of you would have heard about. But that applies to most companies, and it provides a maximum of 12 weeks leave. FMLA can apply for as long as the employee can't return to work. I've gotten questions about whether FMLA could apply to a period of quarantine. I think it could, especially if that quarantine is being recommended by a physician. If your doctor says you can't come to work for 2 weeks until I'm sure that you're not infecting anybody else, I think you could designate that as FMLA leave. And we'll talk about paid family leave and the implications for quarantine in just a minute. FMLA would also apply to intermittent absences for treatment or other health condition-related reasons. So say someone got a contagious disease and they at first needed to be out for 2 weeks, but then they had follow-up doctor's appointments, maybe they got sick again. All of that could be designated as FMLA leave as well. If an employee's physician recommends quarantine, it's likely FMLA applies for that period of time. That could be considered continuing treatment, even if the quarantine is not in a hospital. If the employee decides to quarantine themselves without any medical certification, then FMLA may not apply. I'm thinking in the case of an employee who might not actually be sick, but is perhaps very worried that they're sick, you can't designate FMLA for that period of time. Paid family leave. In New York State, we have paid family leave, which is available to qualifying New York employees to care for a family member with a serious health condition. Serious health condition is defined for paid family leave purposes the same way it is under FMLA. So just like it could under FMLA, the coronavirus and other contagious diseases can qualify as serious health conditions for paid family leave purposes. So when we're talking about FMLA, we're thinking taking time to care for yourself, usually, right? Or you can have FMLA time to take care of someone else as well. But typically when we think of FMLA and we think of a contagious disease, we think taking care of yourself. Paid family leave, contagious disease, does not allow for care of the individual employee. It allows for care of the employee's family members. So if an employee's family member had the coronavirus or another contagious disease, you could try to get paid family leave for that employee to take that time off to care for their family member. I actually had this question last night at about 5:30. I got a call, I was driving home from work, I got a call from a client who said, my daughter has an employee whose daughter just returned from Italy. She was on one of those study abroad programs over in Italy, and the schools, they're sending all the students home. I know this because my sister's in college, and all of her friends who were in Italy and other affected areas are being sent home. So that happened to this client's employee as well. And the New York State, I guess, decided yesterday, some point throughout the day, that everyone returning from Italy needed to be quarantined for 2 weeks, which is something I hadn't heard, but the news changes so fast. So the client said to me, she's home, she wants to stay home to take care of her daughter. Her daughter's not sick, but New York State has said her daughter needs to be in the house, basically under quarantine for 2 weeks. I don't want her to come to work. If she's, if her daughter's potentially sick and she wants to stay home and take care of her daughter, one, I want to let her do that because that's the kind of company we are. We want her to be able to take care of her daughter. And two, I don't want her coming to work because the hysteria among the rest of my employees is no one's going to get any work done if she comes to work. So what are we supposed to do? Anyone have any guesses? You're all looking at me. Anyone in the remote office have any guesses? I said, I wish I'd let that call go to voicemail. That's what I said. No, that's not what I said. I said, well, what do you want to do about this situation? I said, so you don't want her to come to work, right? So, and she doesn't want to come to work. So you got to, she's staying home one way or another because you don't want her to come to work. She doesn't want to come to work. She's staying home. So the question then becomes, do we pay her or do we not pay her? And who pays her? If she's taking care of her daughter, does paid family leave cover that? So at the end of the day, what we decided to do was this. The client, very generous company, they said, listen, we don't want to deal with this hassle of potential disability discrimination. She can work from home to do most of her job. She's going to work from home. We will pay her for the 2 weeks that she's out with her daughter. If she gets sick, we'll reassess it from there. But we don't want her in the workplace. And we're going to submit the claim to our paid family leave insurance carrier and see if paid family leave will pick up some of the costs of her being home to take care of her daughter. Whether paid family leave will apply or not, luckily isn't up to most employers to decide. That's the insurance carrier that's deciding it. So that'll be my first test case to see if paid family leave is going to apply to someone who's being quarantined but might not actually be sick. My guess is the insurance carrier probably will cover it. I don't know for sure, but I'm guessing that they will, especially given the novelty and complexity of this situation. So we will see. But so this, all of that is to say this is very much happening live. I'm sure I will get more questions about this throughout the week, as will every other attorney working on this issue. So it's certainly something that's on people's minds. And frankly, when I picked up the phone and she said, we have a coronavirus case, I said, where are, because it hadn't even occurred to me that the study abroad implications could be affecting someone very close to where I live. So potentially affected employees, that dovetails me nicely because this woman wasn't sick, her daughter wasn't sick, but she could potentially be sick, right? So employees returning from overseas, very much like this woman's daughter. Can an employer require employees returning home from overseas who do not have symptoms? Because remember, if they did have symptoms, we'd put them in the affected employee category, and we would say you need to stay home, you're sick, etc. But if they're returning from overseas and they don't have symptoms, can they be tested for the virus? Can an employer require that they be tested for the virus? The answer, and I hate to say it, some of my answers here are going to be possibly facts and circumstances dependent. Certainly a company or an employer can ask or recommend that the employee get tested for the virus. Say you're coming back from overseas, you're coming back from an area where coronavirus was very prevalent. We're recommending that all employees coming from overseas travel get tested. In most cases, I think employees, for their own ease of mind, are going to want to get tested. If they don't, if an employee objects, the employer then needs to weigh that direct threat assessment that we went through a couple of slides ago, how much of a risk this person would be in infecting others. If the person's not exhibiting symptoms themselves, I would have to say the direct threat at that point is going to probably be pretty low. And then this brings us to, can employees returning from overseas who do not show symptoms be forced to stay home for 14 days by their employer? I kind of jumped the gun on this one because I told you about my call yesterday. It depends. If the Centers for Disease Control are not calling for quarantine, which right now they're not, but New York State is, at least for people coming back from certain countries, forcing asymptomatic employees to stay home may be viewed as discriminatory. I will tell you this, if you're going to pay them, your risk goes down, right? Because it doesn't get viewed as an adverse action in the same way as forcing someone to stay home for 2 weeks without pay would. I would be very careful if you're considering forcing an asymptomatic employee to stay home for 2 weeks without pay. I think there's a real chance that that could be viewed as a disability discrimination issue. Yes?
What about cruise ships that aren't going overseas but obviously are at higher risk?
Yeah, absolutely.
Teresa, will you repeat that question for the audience?
Yes, I was thinking, yeah, I'm going to repeat that question for employees, people in the other offices. What about cruise ships? People coming back on cruise ships that might not necessarily be in affected countries. Should they get tested? Can you recommend that they stay home? I take it your question?
Yes.
Yeah, so I think the analysis would be applied in essentially the same way. I think you could say, listen, if there was an outbreak of coronavirus on the cruise ship, which it seems like most cruise ships are having that problem or at least grappling with that problem, you could recommend that the employee get tested. We're going to go through in a couple of slides some things you can do for employees returning from overseas, questions you can have HR ask them, screening that you can have them do that wouldn't necessarily be considered discriminatory. But yeah, I think you would treat a cruise ship just like a country that's been affected. We've seen cruise ships that have had very serious problems with coronavirus, and not just coronaviruses. I remember times in the past where cruise ships have essentially been little micro cities for disease, infection, and control. Okay, so this, oh good, see I'm right here. Look at that, you're right ahead of me, you're one slide ahead of me. Okay, human resources can instruct all traveling employees whose destination is unknown, who have traveled to a country where infection is prevalent, to contact HR before returning to work. You can ask these types of questions. Where did you travel? What part of the overseas country? Because some parts of different countries are being affected and some aren't. In China, we know Wuhan was very prominent, but parts of other China probably didn't see this level of prevalence with the disease. So you can ask, where did you travel? What part of the overseas country for a cruise ship? Was anyone on your cruise ship infected with coronavirus or another contagious disease? Did you or a family member have contact with anyone with a virus or flu-like symptoms? You can ask that question. Do you have a fever or flu-like symptoms? Does anyone in your family? Are you able to come back to work? You can ask those questions of anyone returning from overseas, especially in an infected area or an area where the disease has been prevalent. The key thing here, catch them before they come back to work, right? So if you have an employee out on leave, you have an employee about to be out on leave, you don't know where they're going, you think they might be traveling, catch them either before they leave or catch them before they come back to your office. Send them an email, call them, do whatever you have to do to get in contact with them so they're not potentially walking into your door and not necessarily infecting your workplace, but honestly creating the hysteria that comes with potentially infecting your workplace. You want to be on top of that before they walk in the door to the most reasonable extent you can be. All of those answers, by the way, depending on them, are going to help you make a real-time case-by-case assessment, and that's all going to go to whether or not this person could be considered a direct threat, whether this person is potentially sick, and you want to put them on leave as a form of reasonable accommodation. Those questions are going to help you answer both of those analysis. Note that this would change if the person returning from overseas has or develops the coronavirus or any contagious disease. At that point, the direct threat analysis likely changes, and it's very likely the employee can be put on leave, either because they're a direct threat or because leave is a form of reasonable accommodation and they are not feeling well and can't perform the essential functions of their job when they're feeling sick. Okay, what about other employees?
Teresa, we have a question here from New York.
Oh, okay, go ahead, New York.
Hi, this might be a unique question. I represent an aeronautical college, so many of our students and employees work daily at international airports. So while they themselves are not traveling, they are in contact with the world. So any guidance that you could recommend would be helpful. Like, do you recommend we compile lists of who these people are? Like, I don't know where, where to start.
Where to start? That's a good question. So I think what's going to be most helpful to you, because you can't really ask where your employees have been in terms of you could with international travel or cruise ship, something like that, because they're in the airports and they're interacting with people from all over the world most likely. What's going to be most helpful for you is directly communicating with your employees. So if you want to make a list of people who work in airports and who have that kind of exposure to people from other countries, I think that's fine. But more broadly, in a couple of slides, or maybe towards the end, we're going to talk about how you communicate directly with employees about what their risks might be and what employees are supposed to do if they feel like they've been exposed to the virus or if they feel like they're getting sick. So I think some type of communication like that, at least letting your employees know that yes, you're not blind to the news, you know what's going on, you know they might be affected, here's what you're doing, here's what they should be doing, would be very helpful for you. So I hope that answers it, at least preliminarily. When I get to my practical tips section, I'm going to go over that in more detail. So if at that time you have more questions or a more detailed question, just let me know and we can go over it.
CDC has protocols for travel employees. Take a look at for all these circumstances for your employees. There's protocols that CDC or the state health department is putting out. So you don't have to make these decisions on your own. There's protocols you can look at.
Okay, so where was it? Okay, yes. So if a person with a contagious disease has been in the workplace, the employer needs to consider the risk to other employees, customers, clients, and third parties who may be in the same location, right? So think of a setting where you have a company, you have a client that comes in, and the client is very sick. It looks like they have the coronavirus. They say to you, hey, oh, do you believe it about this coronavirus? My dad has it. I've been taking care of him all week. Uh-oh. Now you potentially have someone in your workplace who is not an employee, but is a third party who's interacted with your employees and could potentially be infecting people as they go throughout their day. So the employer in that situation, if you have someone who's actually sick and you can't catch them, they've already, so I hate to use the word infected because it sounds so harsh, but they've already exposed your workplace to infection. You have a couple of options, right? You can look at all the employees that they've had exposure to that day and put them on leaves to try to contain it. You can shut down your business entirely for 2 weeks to see if anybody else gets sick. I know that's not going to be the most practical option for most people, but it is an option. And frankly, if you have enough, they have that term like tipping point or critical mass. I think if you have enough employees who are exhibiting coronavirus symptoms, or if you have enough people in the workplace in whatever capacity are exhibiting them, you really should put the thought of closing or at least putting everybody on a remote work plan as a possibility, and we'll talk more about that when we get to the practical tips section as well. The CDC has some recommendations for how you can handle things like that. But depending on what the contagious disease is and when the symptoms are first exhibited, how long you would have to close your business can vary. Obviously with coronavirus, the time period we're talking about is about 14 days. So for employees who have been exposed or in the presence of an individual with a contagious disease, the employer can send the exposed employee home. The period of time will depend on the leave needed and depend on the disease. If the person is asymptomatic, best practice is to make the leave without pay to avoid a discrimination issue. If the person is not sick, they are not protected. They're not entitled to a reasonable accommodation, right? We lose that leave as a reasonable accommodation option. So if they're not sick, your best bet is to put them on leave with pay and not risk the unpaid leave. You don't want them saying, I wasn't sick, my company thought I was sick. They're viewing me as someone who's disabled. I don't actually have a disability. They're discriminating against me. They may go home for 2 weeks without pay, right? That causes a lot of problems. Where if you have someone who's actually sick, they have a much tougher argument, right? Because they're going to say, oh, I'm sick, and my company told me to go home. They told me I couldn't get paid, but I couldn't come to work and work anyway because I was sick. Yeah.
For best practice for hourly employees,
yeah.
Do you do like average of 8 weeks previous pay? Because they could argue overtime is 8 weeks that magic number, or
Yeah.
good number to use. Okay.
I think that's exactly what
Teresa, will you repeat the question?
Oh, sorry. Yes, I'm sorry. Keep raising your hand. Okay. So the question was for hourly employees, what would you use for their pay rate? I think you could use an average of their 8 previous weeks. I think that makes a lot of sense. Same thing if you have part-time employees or someone who doesn't work consistently every week and isn't paid on a salary basis, you could use an average of their weekly time.
Thank you.
You okay, Pete?
Yeah, I'm fine. I was just
Okay.
looking.
Okay, medical inquiries for other employees. So the EEOC actually has guidance on this, and they've released some information on it. So we're going to go through what they say. An employer can make medical inquiries of an employee if the employer believes the employee is, again, a direct threat to the health and safety of others. The EEOC defines direct threat as a significant risk of substantial harm to the health or safety of the individuals or others that cannot be eliminated or reduced by reasonable accommodation. So, if an employee tells the employer that another employee has a contagious disease, the employer must approach and consider the following when deciding whether to approach the allegedly ill or exposed employee. So, that's if one coworker says to you, hey, my coworker Bob that I work with over there all day, he has the coronavirus. These are the factors you have to consider whether or not you can go talk to Bob about whether or not he actually has the coronavirus. And these are set forth by the EEOC. So the EEOC says, before you go talk to Bob and see whether or not he actually has coronavirus, you need to consider the following things. The relationship of the person providing the information and the person about whom the information is being provided. If Bob and his coworker have had a blood feud in the workplace for the past 7 years, and they hate each other and they make frivolous complaints about one another all the time, that is probably not going to be a good enough reason to go over and ask Bob, hey Bob, do you have the coronavirus? Probably not going to be good enough. The seriousness of the medical condition at issue. Obviously, some medical conditions are more serious than others. If it's a cold, probably not going to cut it. Coronavirus, probably, especially given the level of intense scrutiny it's under lately, both in the media and in the workplace as well. The possible motivation of the person providing the information. Again, do these two people not like each other? Is one person trying to get the other person's job? Are there other things at play? Or do you think the person's just truly trying to say, hey, listen, I think this person is sick, I don't think they can do their job, and I'm worried about them getting other people sick. Those are things you can and have to consider under the EEOC's analysis. And then other evidence the employer has that bears on the reliability of the information provided. So these are all just a fancy way of the EEOC saying, consider your source, right? When you're going to talk to another employee about whether or not they potentially have a contagious disease that's affecting other employees in the workplace, consider the source of that information. So EEOC gives this example. Bob and Joe are close friends who work as copy editors for an advertising firm. Bob tells Joe that he's worried because he's just learned that he had a positive reaction to a tuberculin skin test and believes he has tuberculosis. Joe encourages Bob to tell their supervisor, but Bob refuses. Joe is reluctant to breach Bob's trust, but is concerned that he and other editors may be at risk since they all work closely together in the same room. After a couple of sleepless nights, Joe tells his supervisor about Bob. The supervisor questions Joe about how he learns of Bob's alleged condition and finds Joe's explanation credible. Okay, so that was the EEOC's example. And then they said, and this was their guidance on the example, because tuberculosis is a potentially life-threatening medical condition and can be passed from person to person by coughing or sneezing, the supervisor has a reasonable belief based on objective evidence that Bob will pose a direct threat if he in fact has active tuberculosis. Under these circumstances, the employer may make a disability-related inquiry or require a medical examination to the extent necessary to determine whether Bob has tuberculosis and is contagious. So, subtuberculosis for your contagious disease or ailment of choice, and you have a good example of how the EEOC views that should be treated when you've been alerted to it by a coworker. Okay, that takes us nicely into medical screenings and employee privacy. So a lot of people have been asking the question, can I require that my employee who's coming back from an infected area or an area where infection is prevalent to get tested for the disease? So, medical screenings. If any of you have ever dealt with this topic under the ADA, the New York State Human Rights Law, this is not something that the law takes lightly. You cannot just broadly medically screen your employees. You have to have reasons for doing that. Applicants are different. Applicants are different. People have been offered conditional job offers pending an examination are different. But actual employees, which is what we're talking about here, it's a high bar to be able to medically screen them. So when we're talking about contagious diseases, and I think I mentioned this earlier, your best bet is to recommend the employee go get screened and hope they do that on their own, right? You have an employee coming back from an area where the disease is prevalent. You say, listen, I know you know that coronavirus is all over China right now. You're just getting back from a month-long study abroad trip in China. We recommend that you go get tested. In most cases, the employee's probably going to say, okay, great, I'll go get tested, fine, no problems, right? In terms of requiring the medical screening, again, we see that direct threat analysis here, and in that case, the employer can require medical screening when the employee will pose a direct threat due to a medical condition. For an asymptomatic employee doesn't appear sick, is saying they're not sick, requiring them to get a medical screening just because of the area that they've been to, I don't think it's an impossible hurdle to cross or to cover, but I don't think it's going to be the easiest analysis either. So the assessment of whether an employee is a direct threat must be based on objective evidence. In most cases, that's medical documentation. An employer may elect to have an employee undergo a medical assessment to determine whether the employee can perform the essential functions of the job without being a direct threat. So I'm not saying medical...
Teresa, can you hear me?
Yeah.
It's Hermes in Albany. Yep. Just as you're talking about the employee testing, though, I just want to interject that we have to keep in mind that at this point, the limits on testing for the coronavirus, right? The approval processes are just starting, so the availability of testing is not yet widespread. And as this is being discussed, you also have to keep in mind that there are protocols that the healthcare authorities are putting into place as to who they will test. So that's going to put some limitations on in terms of what employers can expect from their employees.
Agreed. Very good point. As testing protocols and ability to test develops, as testing protocols and ability to test develops, so too will an employer's ability to actually be able to give a test that they can mandate that their employees.
I have a question regarding cost, because are these tests going to be, they potentially could be expensive? Would we expect the employer to pay for them?
Well, I would think it would be covered under the employee's health insurance policy. If you're,
there are a lot of high deductible plans, and employees are not going to want to put the, front the money or to pay for that.
Okay, so I think you take it two ways. So if the employer is forcing the employee to get the test, let's say they've made the direct threat assessment, guidance from the EEOC and ADA says if you're making the employee get the test, you have to pay for it. The employer has to pay for it. But if you're recommending the employee get the test, you're not forcing them to do it. You're not saying you must get tested or you can't come back to work. If you're just recommending that they get the test, I think that would be paid for by their insurance. That answered that question. Okay, so if the medical screening, suppose you got one, suppose they got one from their own doctor, supports the finding that an employee is a direct threat, the employee can be removed from work until that status is abated. Again, we've talked about removal can be with or without pay, depending on the employer's policies. Perhaps they can use accrued time off as well. So that brings us to employee privacy. When informing coworkers of potential exposure, you need to protect the privacy of the ill employee to the maximum extent possible. I realize with the amount of hysteria surrounding coronavirus, that is probably not going to be practical in all situations or even possible. But if there is going to be gossip and rumors spreading throughout the workplace about who has what, you need to be on top of it. You need to try to tamp it down, and you need to not be spreading those rumors as supervisors and representatives of the company. So please protect the privacy of the ill employee to the extent possible. If you have to alert people to an outbreak of coronavirus in your workplace, don't use the employee's name. Everyone's probably going to know anyway, but you don't need to say the employee's name. Don't provide personal details about their illness, how they became exposed, whether they have a family member exposed, whether they've just traveled. All that is just going to let your employees identify the affected employee. And please avoid stereotypes. We're going to talk more specifically about stereotypes in the discrimination section But stereotypes are obviously something that come into play whenever a specific region of the world is infected with the disease, and we want to avoid those at all costs. Also, when it comes to employee privacy, employees may have the right to discuss with one another their disease-related workplace safety concerns under the National Labor Relations Act that protects workers' rights to safety. I think in all likelihood you cannot prevent employees from talking about that at work. They may object to working with a coworker or a third party that has been exposed to a contagious disease. They do have the right to object to that or report to the employer that another employee has a contagious disease under OSHA without fear of retaliation. Whether or not they actually need to continue to work with that person is something the employer is going to have to decide depending on whether that person they're reporting actually has the disease, whether or not they're contagious, how closely they work with the person making the report, etc. But the right to report alone is protected under OSHA. Which brings us very nicely to OSHA. So, as I said, OSHA has released a webpage on this. They are among many of our agencies that have released a webpage specifically on coronavirus. I found OSHA to be very helpful, but generally speaking, the Occupational Safety and Health Act's General Duty Clause requires employers to furnish each worker with a place of employment which is free from recognized hazards that are causing or likely to cause death or serious physical harm. So that's what we call OSHA's General Duty Clause. I talked to our OSHA expert up in Albany, Mike Billick. He said that the coronavirus would definitely fall under the General Duty Clause. You have a duty to keep the workplace as free as possible from recognized hazards that are likely to cause death or serious physical harm, and that includes the coronavirus. So, OSHA does have a separate safety standard for certain types of illnesses. They don't have one for coronavirus, at least not yet. Although, as Hermes mentioned, the government is working very quickly to enact regulations and guidance on this issue. They don't have one yet, but the employer does still have a duty to keep the workplace free from contagious diseases. So what does that look like? So OSHA just gives us this general duty clause, but they don't tell us exactly how to apply that to coronavirus. So in talking with Mike Billick, our OSHA expert, he suggested the following. Make sure your employees have protective equipment if they're working with, particularly in a healthcare setting, patients who might be exposed or might have the virus. If you have an infected employee, put that employee on leave. Don't let that employee start infecting other people, right? Practice good procedures for cleanliness in the workplace and mandate that your employees do the same. Wash hands, clean surfaces, cough into your elbow, all the common sense things we hear every flu season. And we will talk more about those when we get to practical tips as well. But those are all ways that we can show OSHA and show our employees that we are trying to keep the workplace as free as possible from this illness or this hazard, which in this case would be the coronavirus. OSHA also has a record-keeping requirement that mandates the recording of certain work-related injuries and illnesses for covered employers. OSHA has said in the webpage that they released on coronavirus that coronavirus is a recordable illness when an employee is infected on the job, from a coworker, from a patient, from a client. Oh, yes. Sorry, I had a couple eyes really wide here. Yes, so that is a recordable illness for OSHA purposes when someone is infected on the job. Remember, not just infected. If they're infected from a family member or infected from overseas, or you don't know how they're infected, okay. But if they are exposed at work, and it's pretty likely that they have been exposed at work, that is a recordable illness for OSHA purposes. So all employers, regardless of size or industry, must record a work-related coronavirus infection if it results in a fatality or a hospitalization. Illnesses not resulting in hospitalization must be reported yearly on March 2nd to OSHA. Hospitalizations must be reported within 24 hours to OSHA, and all fatalities within 8 hours. So that guidance is available online. I encourage you all to check it out. OSHA recording can be done by forms available through the website, and it requires covered employers to post a summary of injury and illnesses each preceding year from February to April up in the workplace. So I'm not going to do a treatise on OSHA right now. We don't have the time and I don't have the qualifications, but if you have more questions about OSHA, please let us know. We can get you more information on that, and their website is a really good place to start with the reporting requirements as well. Okay, preventing discrimination. Just checking to see how I'm doing on time. So Employers should make all employees, especially supervisors, aware that discrimination is illegal. Hopefully all of your supervisors know that already. Hopefully all your employees know that already. But make them aware that that can apply to the coronavirus as well. So discrimination can take many forms, such as preventing an Asian employee from sitting near non-Asian employees for fear of contamination. That would be discrimination. Prohibiting an employee who has recently returned from overseas, who doesn't show symptoms from coming to work unless they're put on paid leave. We've been talking about this all throughout. That could be a type of discrimination if the person is not actively showing symptoms. Allowing employees to spread rumors that an Asian employee who is out sick has the coronavirus. That is going to be a type of discrimination. Not necessarily, and the key there, remember, is allowing, right? So if employees are spreading rumors and a supervisor doesn't know about it, the company's not on the hook for that. But if a supervisor is aware that an employee is spreading discriminatory rumors and they don't do anything about it, that's when the company could have legal liability there. Employers may ask about travel plans for employees as long as they do so for every employee. This includes questions for employees returning from an unknown destination. They may ask employees who are ill to stay home from work as long as they do so for all employees with similar symptoms. Do not just do it for your Asian employees. Do not just do it for your white employees. Don't differentiate based on race, gender, etc. The EEOC released Pandemic Preparedness in the Workplace that addresses this discrimination topic. It came out in 2010, but I think it's still relevant to what we experience today, particularly as coronavirus might be concerned. So the EEOC says employers may not ask employees if they have health conditions that would make them more susceptible to the virus. Do not go around saying in a meeting, everyone who's immunocompromised, raise your hand, or everyone who's over 60, raise your hand because you're at higher risk for coronavirus. Do not do that. The EEOC is saying don't do it, and I hope you all had the good sense not to do that in the first place. The EEOC says you can ask employees if they're experiencing symptoms consistent with the virus. We talked about that already. You can require employees to wear personal protective equipment, gloves, glasses, whatever it might be. Employers may require hygiene practices such as hand washing, coughing into your elbow, and employers may ask employees why they have been absent from work. If someone's been out for 2 weeks, you can say, where have you been for 2 weeks? That's not a discriminatory question. That's just a question that you are allowed to ask. Okay, so that brings us to practical tips for employers. That's a nice dovetail because those things basically all were practical tips. So that brings us to a couple more. Encourage hand washing among employees. Regularly clean your workplace. At our office yesterday, we all got new bottles of hand sanitizer. It's very exciting. It's like getting a gift from work. So if you want to do that for your employees, you can do that as well. Tell employees who are sick to use good judgment about reporting to work, especially if they have a fever or flu-like symptoms. They do not need to be a hero and come to work if they are sick. Allow employees to work from home if appropriate. In our digital age, a lot of employees can work from home. If you can make that possible, make it possible. Require employees to notify HR immediately if they're diagnosed with a contagious disease. You can have policy language on that. If an illness is suspected, have supervisors and HR carefully document basis for that suspicion. So you can't just say, okay, Bob, we're going to put you on leave because you're sick. Bob's going to say, I'm not sick. And if he sues you, what are you going to have to say back? You're sick, and the court's going to go, how did you know? You're going to have documentation. Bob's sneezing. He's coughing. He can't breathe when he talks too much. All of his coworkers have complained about him being sick. He told me he was taking care of his daughter who has a very serious coronavirus infection. All those types of things are documentation that you can prove before putting someone on leave who doesn't want to be on leave that they are actually sick. Train employees, especially supervisors, to recognize and prevent discrimination. That should be obvious. CDC, Hermes alluded to this, but they have said you can create an infectious disease outbreak response plan. So I included a lot of bullet points that they have in this slide and the next slide. Obviously that guidance is also available online. I encourage you to check that out and see how it would apply to your specific company. I am running a little tight on time, so I'm not going to go through each and every one of these, but I think the key ones would be figure out how you're going to communicate with your employees if an outbreak occurs in the workplace. Figure out how your employees are supposed to communicate with you if they're sick. What are they supposed to do? They're supposed to call, they're supposed to email. Who are they supposed to call? Who are they supposed to email? Determine how you're going to run your business if a certain percentage of employees can't make it to work. Can you work remotely? Are you going to have to shut down? Things like that. Develop policies on travel. That seems obvious. Look at your current HR policies to make sure they're compliant with the current law. Use CDC resources. There's a lot of misinformation going on about the coronavirus right now. I saw I think it was on the news, some people are asking like if they can drink bleach to prevent the coronavirus. That is not good. There's a certain level of misinformation going on out there. I don't know what different levels of information your employees would have, but make sure that if they're getting information, that it's good information, especially if it's coming from you. We have the CDC for that. Employee communication, I alluded to this when I was answering the question about employees that work at different airports. You can communicate directly with your employees. Listen, we know there's a coronavirus outbreak going on. We are aware of it. This is what we're going to do. This is what you should be doing to prevent the spread of the coronavirus. It can also inform employees of government sources where up-to-date, accurate information is provided. Schoeneck King provided us as employees with one such notice yesterday. So it's definitely something that you can do for your employees, just to let them know if you have questions, this is who you talk to, this is what we're doing, this is what you should be doing. It can help us prevent the spread of misinformation. So, tricky situations. I have a couple of examples, and then I'm going to be all set. So, Mike has recently returned from a trip to China with his family, including his wife and young children. Mike tells you, his supervisor, that he believes his daughter has contracted coronavirus, and he's been taking care of her at home. What do you do? I'm not going to make you all answer because we don't have time for that, frankly, but what should you do? Maybe PFL if his daughter is sick, right? It sounds like his daughter is ill from something. He's been taking care of her, so even if it's not coronavirus, if he's been taking care of a child with a serious health condition, that may be paid family leave qualified. If you're worried about Mike bringing the coronavirus to your office, you can say, okay, Mike, listen, take care of your daughter. We're going to put you on paid family leave. We're also going to pay you to supplement the paid family leave payments, get you up to 100% of pay. Take 2 weeks off, wait till your daughter gets better. Tell us, Mike, if you get sick. We want to know if you start exhibiting symptoms. Tell us if you need additional time to take care of your daughter. All of those types of things. Okay, we have Stephen, an employee whom you supervise, appears to have grown increasingly nervous about the coronavirus over the past few weeks. 3 days ago, he stopped coming to work and told you he was afraid to leave his house until the coronavirus was no longer spreading. What do you do about Stephen, an employee who's really nervous about the coronavirus? There's a trick to that. There's always a trick to questions, right? But if you have an employee that's super nervous about coming to work and they're saying, I'm too stressed out, I'm having anxiety, they're potentially exhibiting symptoms of a completely different disability. They may need to be accommodated for that on a separate basis. But generally speaking, someone who just says, I'm not coming to work because I'm afraid of coronavirus isn't going to be protected. They have to come to work unless there's a basis for that. Okay, your employee Sue has been sneezing and coughing at work. Coworkers have reported to you that she appears out of breath and has mentioned having headaches. When you confront her, she says she's fine. She refuses to leave work or to see a medical provider. To me, this is the trickiest of the situations that I just posed. So, obviously, you can recommend to Sue, listen, Sue, you need to go see a medical provider. You can give Sue the rest of the day off and tell her she needs to use that time to go see a provider. You can put her on paid leave independently. Tell her she needs to bring medical certification back to you when she returns to work. Obviously, you're running a risk with each of those things. If Sue's insisting she's not sick, that's where documentation is going to come in to be critical for all of you guys. You have coworkers who are saying she's been sneezing, she's out of breath. Maybe you've noticed that. You need to get all that stuff documented contemporaneously. That way when Sue says, they made me leave and go to the doctor, and that's a disability discrimination, you could say, no, she was really sick. We were very worried about it spreading to other employees. Here are 5 signed employee statements saying what symptoms they observed and when. But that should be an extreme case, I think. Most people will go to the doctor. And then finally, Darren and Calvin are coworkers who have disliked one another for years. Calvin has been absent from work for the past 3 days, and Darren tells you, his supervisor, that Calvin's recently been to China and has the coronavirus. Calvin's also been spreading this information to other employees who are becoming very upset. What do? That's our EEOC, consider your source guidance, right? So someone who's out for 3 days, they could be out for 3 days for any reason, right? Maybe they're on paid vacation for 3 days. Maybe they're out for 3 days to take their kid to college. Maybe they're out for 3 days because they broke a bone or you have no idea. So So in that situation, if you're considering your source, I think you probably would not have enough to say to, what am I saying? Calvin, do you have a coronavirus or some sort of symptoms? What you could say to him when he comes back to work is, why have you been off for 3 days? That's not a discriminatory comment. Okay, so I'm going to stop there, and I think we're turning to Dr. Halsey next before we get to Monica. And if anyone has questions that I didn't get to, I will be here afterwards, and I can answer questions from remote offices at that time.
Good morning. We're very lucky to have with us this morning Dr. Ann Falsey from the University of Rochester. As part of her background, she did an infectious disease fellowship at Yale University and the University of Rochester. Her research includes numerous viral respiratory pathogens, including influenza as well as coronaviruses. I'm going to turn it over to Dr. Falsey.
Well, thank you. These are busy times for we respiratory virus nerds. So, coronavirus is taking up a lot of my time. I'm going to give you sort of the scientific medical perspective to add to, I think, what you've just heard. Because there is a lot of misinformation, and this beginning slide just sort of illustrates the fear factor. I mean, you turn on the news and it's just really very distressing. So we're going to talk about SARS coronavirus 2. So it's the second SARS virus, and it causes a disease called COVID-19. If you could advance. So, one thing that when you listen to the news, they don't tell you or they don't emphasize is that coronavirus has been around for a long time. They were first discovered in the 1960s. There are two coronaviruses, OC43 and 229E, that have been circulating and causing colds and bronchitis. But it is true that there's lots of different coronaviruses that infect animals, and they cause a variety of diseases: hepatitis, gastroenteritis, pneumonia. And then when SARS-1 came around in the year 2001, people got interested again in coronavirus. They didn't pay too much attention to them. And now there's all these nice new molecular tools, because some of these viruses are actually hard to grow. They discovered two other coronaviruses, NL63 and HKU1. And again, these viruses were very similar to the original ones causing coughs and colds. But now we have two new pathogens, MERS, the Middle Eastern respiratory syndrome virus, and now SARS-2. Next slide. So this is the family tree of coronaviruses. There's alpha and beta, and there's little limbs on the family tree. The current SARS-2 is very genetically similar to a bat-like SARS virus, but it's also quite similar to SARS-1. And it's interesting that the origin of almost all these nasty, scary viruses are bats. For whatever reason, the bats don't seem to get ill. But people don't have a lot of contact with bats, and so usually there's another animal intermediary. So for SARS-1, it was the civet cat, which is sold at the Chinese, food markets. Usually they have a lot of live animals. And then for MERS, it's actually camels. The bat is the Egyptian tomb bat, and then people have more contact with their camels, so that's the spread to humans. And with this current virus, and next slide, I just had to show you this picture because I think it's just amazing. The thought is that, next slide, the current coronavirus comes from this thing. It's called a pangolin. It is, it looks positively prehistoric. But apparently it was on the extinction list, dangerous, because it is so popular in Asia as a source of medicines, a source of food, so they sell them at these animal markets. And so that's one of the theories as to where the animal intermediary that this virus came from the food markets in China. Next slide. So you probably have seen similar slides to this on the news, where the virus, it initially was identified in December in Wuhan, China, which is a very large city. in China that some of us weren't aware of how big a city it is, and it's really an economic hub. There's a lot of American companies that have offices in Wuhan. And it shows that from January to the end of February how significantly the virus was spreading. Part of that is not only spread, it's identification. That they finally figured out they had a novel coronavirus, and then you don't know what you have until you can test for it. The bar graphs on the side put the current coronavirus in perspective in comparing it not only with the deaths, but cases with the other two coronaviruses that jumped species. So you can see on the top that the number of cases, and every day this updates, it's sort of, yesterday it was 90,000, I don't know what it is today. So this coronavirus is clearly much more transmissible. But when you look at the bottom set of graphs, that the case fatality rate is not nearly as high as with SARS or MERS. So in a way that's reassuring, but it's also, because the disease is milder, it certainly has allowed spread. Where the other viruses, people were so ill that by the time they were very ill and they were shedding a lot of virus, they were already in the hospital and people could identify they were sick. So this is where we are sort of today. Next slide. So I updated this yesterday and it's already out of date. So globally, there's about 87,000 cases, most of which are still in China, but outside China is the areas that the most rapidly growing number of cases. The rate of increase in China has actually slowed. And that's interesting in that it might suggest, and a lot of this is conjecture, in that it has infected over 50% of the population, and therefore people are immune, and therefore it's not quite so transmissible. But until you can actually do serological studies to see who's been infected and not, you can't really say. But that would be one reason that things are slowing in China. They've also instituted, some environmental things and social distancing, so that may be having some effect. The current case fatality is about 2 to 3. And again, until you really know what the denominator is, that's really hard to say that it's really the true case fatality rate. There may be a lot of asymptomatic, very mild infection that's not being counted. The R0 is how transmissible is this virus. And so it's about somewhere 3 to 4. So one infected person will spread it to as much as 4 other people, which is quite a bit. It's pretty transmissible, and it's felt to be somewhere around the similar transmissibility and seriousness of the 1918 pandemic flu.
Was that the Spanish flu?
Yeah, yeah. Next slide. There's a whole lot of socioeconomic and world event. I mean, the 1918 flu, a lot of the deaths were probably because it was World War I and people were jammed together and they didn't have antibiotics, and so there's a lot of reasons for those secondary bacterial infections. Okay, so when I updated this yesterday, there were 43 U.S. cases. Apparently now there's 100. So this is already quite out of date. And there's very clearly community spread in Washington State, and probably in other places as well. The folks in Washington now have had, they've done genetic sequencing. So they've taken viruses from 2 different people who had no travel history that appear to be community spread, and they've sequenced the viruses. And these 2 people don't know each other. They're in different parts of the state. And the viruses are genetically almost identical. So it's unlikely that they were brought in from China separately. It suggests in this their study that it's been actually spreading in Washington State probably about 4 to 6 weeks prior to anybody knowing that. So it was around mid-January, that the first U.S. case was identified coming in from China. It was in Washington State. But you think back to, and I really didn't understand what Wuhan was like. It's this huge economic hub. And so you can imagine there were people going back and forth before then. And for the most part, it's relatively nondescript mild illness that there was in fact spread before anybody identified it. So, you only know what you have once you start testing. We've really not been doing much testing. It's all been driven by, being a person of interest, having travel history. And so until we start doing very widespread testing, we don't know what we have. Okay, next slide. So to help put it in perspective, because again, you listen to the news, you can scare yourself silly. This is putting the current coronavirus in perspective in terms of the case fatality rate and the R0, which is the transmissibility of it. And so what you can see going down the list is, it's not Ebola, where there's a 70% case fatality rate. But if you look over at Ebola, the R0 is 1 to 2. And it's because people are so incredibly sick, they're not out there spreading it around. It is, in fact, a fairly transmissible virus with close contact. So you look up and down the list and you see the 1918 flu, the Spanish flu, the case fatality rate was about 3, and that's similar to what we see with the novel coronavirus, and that the transmissibility was similar. It is not as bad as SARS-1 and MERS, or even avian flus. Avian flus, the case fatality rate was much higher, but those were much less transmissible. Some of the animal viruses, you really have to have contact with the animal, that they don't have efficient human-to-human spread. This virus clearly does. And so, it's not Ebola and it's not a cold. It's, it's a serious respiratory viruses, and the majority of illnesses will be mild. The major risk factors are underlying disease and age. So I don't think panic is appropriate, but it's appropriate to start making plans and trying to figure out what we should be doing to try to contain this virus to slow it down. Next slide. So just a few questions that this is actually a nice resource, and what I would recommend rather than surfing the internet is to look at the WHO and the CDC website, because the information is accurate. There's a lot of crazy stuff that's said on the internet, and it sounds legitimate. It's very hard to tell. So I would stick with the CDC. So who is at risk for COVID-19? I think we're all at risk. This population we are not immune to this virus. So if you were exposed, everybody would get it. But who is at risk for severe disease? Again, the data coming out of China and now other places is the severe disease is generally older people with underlying heart and lung diseases, the usual things that are put people at risk for flu and all the other respiratory viruses. That's not to say that there will not be the occasional young healthy person that gets a terrible pneumonia and ends up on a ventilator. The same thing is true, though, for the usual seasonal flu. Every year I will see some young healthy person with no apparent risk factors who is desperately ill from the flu. And we just put in a grant to try to figure out why. We don't know what that is. Is it genetics? Is it, what's going on there? But for the most part, healthy people, even if you're older, I don't think our risk is tremendously high. That isn't to say that you should not you don't want to get it. Try to prevent it, but there's no reason to panic. When is someone infectious? It's very clear that this virus starts out extremely mild. The incubation period can be as long as 2 to 3 weeks, where it's just sort of percolating. You maybe don't feel so good. You have very nondescript symptoms, and that you are infectious during that period. And that, a lot of what I'm saying, changes daily as we get more data. But it is clear that you can spread the virus with either no symptoms or minimal symptoms. Which body fluids are infectious? From what we know now, it's really respiratory secretions. So, what's coming out of your nose or, out of your cough. They have been doing blood and stool. With SARS-1, it was in stool and it was infectious, but I've not heard that they found this virus in any other body fluid at the present time. It's transmitted, we believe, by what's called large droplets, and they referred to that in a previous presentation, and fomites on hands, and so a large gob lands on a table and that stays there. If we could go back to the other slide, it's recommended that that people get put on isolation with this negative pressure and these special kind of N95 respirators. That is probably not necessary. It's an abundance of caution. The way this is spreading, if you look at the top, the or not is somewhere around 2 to 3. They said 2 to 5. But when things are really truly airborne, like measles and tuberculosis, smallpox, the R naught, if you come down to measles, is 12 to 18. It's much higher. So if you cough in a room, you can infect everybody in the room. This spreads like it's really droplets. So what's that mean? You can go to the next slide. That means that you really need a relatively close contact. So droplets fall out of the air in about a yard. They don't float around. Like if I cough, it would go about 3 feet from me, and then they would settle out onto surfaces. So that means that regular masks are protective in people who are taking care of people actively coughing, and we'll get to masks. But you can pick it up from surfaces. They've done some studies where this virus actually does remain infectious for quite a long period of time. There was one study published that was 9 days. So on hard surfaces, non-porous surfaces, viruses last longer than on like cloth or tissues or stuff. And hands have some natural antivirals in them. But anyway, it's a good case for just turning into Lady Macbeth and washing your hands all the time. How do we test a patient? At the present time, it's a PCR. It's a molecular test, and they swab the nose and throat. It is not widely available. It's a huge problem. So the CDC has sort of published their test parameters. The local and state health departments are supposed to get about 1 million kits by the end of the week. That's still not enough to do widespread testing. So here in Rochester, both at RGH and at Strong, there is a push now to develop a sort of homebrew molecular test. We always get into legal issues with this. It's not CLIA certified. Should we be using it to take care of patients? But extreme circumstances require that sometimes you do things a little bit outside the box. The New York State Department of Health has an expedited approval for these kind of tests. So once you have a test, you can start testing widely. Is hospital admission needed? No. In fact, if somebody has this and they're not short of breath or too weak to get up, or they're able to eat and drink, you really tell people to stay home and self-quarantine. So the reasons for admission are the usual reasons for admission. They're not anything specific about this virus. Because it is a more serious virus and a high percentage of people do become ill, you wouldn't want to be cavalier. So you make sure that people are being monitored and checked in on. Pets and animals. It's kind of an unknown question, honestly. It is an animal virus. I mean, there's lots of coronaviruses, so theoretically it could spread. I did find a couple of articles that so far they have not found it in any dogs, and I love my dog, but it sort of grosses me out when it tries to lick me on the face. So, keep the licking to a minimum. So next slide, clinical features. Unfortunately, in the mild cases, there's really nothing hugely distinguishable about this virus. It can present like a cold. You can have a runny nose. You can have a mild cough. When the people are more severely ill and end up in the hospital, this is a study from China, the mean age for people that actually needed hospitalization was 55. Fever is common. So a lot of respiratory viruses, fever is not a big one, but certainly with flu it is. So most people had a fever, most people were coughing. There were some changes in their blood tests that could help us be suspicious, but those are actually not terribly pathognomonic for this virus. It happens with almost any virus. Lung involvement when you're getting short of breath and not feeling well enough to be in the hospital is nearly universal, and even if you don't see it on a plain old chest x-ray, if you do a CT scan, you can see sort of these, they call them ground glass opacities. It's just sort of a diffuse change in the lungs. Bacterial pneumonia causes a sort of socked-in area where viral pneumonias cause sort of diffuse changes. So there are things on scan that would make somebody suspicious. But the risk of death for the average person is quite low, and it's really older people with comorbidities where we get concerned, which kind of raises just a word about the deaths you probably heard about from Washington State. They had 4 from a long-term care facility. One gentleman was 50 years old. But the fact that somebody's living in a nursing home, that is not a normal average person. They must be quite frail. The other thing to think about with the death rate from nursing homes, many people living in nursing homes have living wills, and they do not want extra ventilatory support. So it's hard to know how to interpret those. Certainly, you don't want the nice old people in the nursing homes dying, but it's just hard to assess what that means for the general population. Okay, next slide. So I think it's important to point out, because this is always a concern, what about kids? It is really unusual with this virus that it really does not seem to be making children sick. I mean, coming out of China, there's almost no cases, like 9 babies that they reported on, nobody died. So very reassuring that illness is quite mild in children. I cannot believe that they're not being infected. That biologically just doesn't make any sense. I think that they're maybe the nice little vectors for spreading it all over everywhere. But fortunately, unlike the flu, a bad flu season every year kills children. And fortunately with this virus, as bad as it is, the little ones are spared. The other issue is pregnant women. We don't have a lot of data in pregnant women, but it does not seem to be in breast milk. It does not seem to transmit vertically from the pregnant woman to the baby. But this is all based on very few cases. And unless the mother was terribly ill in an ICU on a ventilator where that illness stresses the fetus, there do not appear to be congenital abnormalities. But again, this is based on very little data. Next slide. So you probably know that there's no current vaccines or treatments. We are, at the University of Rochester, we're part of the Vaccine Treatment and Evaluation Unit that's an NIH consortium. We will be testing this drug shortly. It's an intravenous medication for hospitalized patients. Once we have community transmission and we have cases in Rochester, which, I hope we get all set up to do it and we don't get to do anything, but I suspect we will. There are also vaccine candidates being tested in this system and throughout the unit. Realistically, though, a vaccine would not be available generally for a year, which is a good reason for sort of social distancing and the other things we do to try to put off people getting infected, so you can come up with some antiviral treatments, potentially some vaccines, and also not to overload the healthcare system. If you can sort of stretch out the epidemic, then sick people who need to go to the hospital will have a place to go. Next slide. So the CDC says be prepared, but what does that even mean? Last week I got this panic phone call from my 33-year-old son living in Brooklyn. It says, I just got a text on my phone from the CDC. It says to be prepared. What do I do? It's crazy. They say these things and they don't actually tell you what they mean. I listened to a wonderful piece on NPR who was saying some very practical and useful things. So you already heard about, for employers, consider how you would have people work from home if community spread is widespread. Obviously, sick people need to stay home. They shouldn't be coming to work anyway. Don't stockpile masks. And so, me in the hospital seeing somebody actively coughing with a fever, I need a mask. But they say, and I think this is true, that, just walking around all day long with a mask on, it gives people a false sense of security. The mask gets dirty, they're touching their face and their eyes anyway, so it's really not recommended. Wash your hands a lot, try not to touch your face. It's sort of a good training period of like, try not to be touching your face. Get some hand gel if you can afford it. They're jacking up the price, or those bleach wipes, because it really does survive on hard surfaces pretty well. So, I think about my 97-year-old dad who's still living at home independently, that even if he was to become a hermit and stay home, because he would die if he got it, that just bringing in the groceries, I was thinking, well, I might want to wipe them down with some bleach wipes. It's also to be considered that you might have 2 weeks of non-perishable food and 2 weeks supply or even month supply of essential medications. And the reason for that is if it's really epidemic and they're saying they're kind of closing businesses and movies and restaurants, the last thing you really want to be doing is standing in line at the drugstore, with all the other, if you're really going to kind of hibernate, you need some things to hibernate. So without being a crazy survivalist, I think this is reasonable. And in fact, when these recommendations, we were thinking about them, I was thinking, well, maybe I should have some non-perishable food on hand. And I thought, well, how stupid is that? I'm going to be in the hospital taking care of these sick people. So, next slide. And I think an important thing is to keep your sense of humor. There is only so much you can do to protect yourself, so you want to do sensible things. You don't want to panic, and you just have to live life without being too incredibly freaked out. Next slide. And if you wanted to write down some important numbers, the health department, they have a 24-hour hotline if you start getting really flipped out. So I was hoping it was only going to be 15 minutes and you could have some question time, but I've run out of time. You have 1 minute to ask me questions.
I was curious, the flu when like the weather breaks and it seems to, is there any hope with this that will get better?
There's a hope.
If you repeat the questions.
Oh yeah, so do we think that maybe as the weather gets better, the cases will diminish? And it's a complete unknown. I think when you have a completely non-immune population, probably not. You will remember in 2009 that the first sort of big waves of the flu were in June. And so, but I do think people are outside more. There's not so much crowding, so some of it may lessen up. And in addition, things will just be more tolerable. You can sit out in your backyard in your lawn chair, instead of, hibernating in your house looking out at the drizzle. So it's really not known.
Do you expect testing in the outpatient world anytime soon?
So not anytime soon. We just don't have the capacity. And so I think that the first priority will be to be more significantly ill people in emergency rooms and in hospitals. I think the hope is to try to direct people who have really mild symptoms not to go to the doctor or the hospital because they're afraid they have coronavirus and they want testing, because it's just not available at the present time. And as I said earlier, the reasons to go to the hospital are the usual reasons to go to the hospital. You're that ill and you're not feeling well that you might need further care, but not specifically, I'm freaked out I have coronavirus. So, no.
Thank you, Dr. Falsey. We're going to turn it over to Monica Barrett now.
Hi, everyone. I wanted to thank Dr. Falsey because I think you're the calmest person I've talked to in the past 2 days, because I've been working with a lot of my clients and a lot of attorneys who are trying to read the latest from the CDC, staying up until midnight. And in fact, I just wanted to give you an example. Last night I was, in preparing for today, I was keeping up with the CDC alerts and the Department of Health, and I was talking to Hermes, and I had found something that one higher education institution was doing, and it referred to a Department of Health directive that students returning from Italy had to be isolated for 2 weeks, even though they were asymptomatic. And I said to Hermes, I can't find this on the Department of Health anywhere, and he couldn't find it either. And then we figured it could have been a phone call to the Department of Health, and someone who gave advice over the phone could have given that advice. So I just wanted to emphasize that the situation is changing by the minute. So we have to keep up with looking online. And after Dr. Falsey, I'm going to ratchet it up a bit, the anxiety level as I go through this. So, and the other thing I wanted to point out is that when we look at these issues, there's a legal answer, because Hermes and I last night couldn't find the Department of Health directive. But then there's a risk assessment answer that might be the practical decision that higher education institutions and K through 12 schools, private schools, are making to make this, to figure out what to do in these situations. So what I'm going to do is, to close out the program, I will not go until 11:30. So I want to go through just describe the global industry of higher education in general, and cover what different institutions of higher ed are doing, and also the messaging specific higher education institutions are giving, and then talk a bit about the impact of this situation, about bringing students back from Europe and canceling conferences, what kind of impact that is having on higher education institutions. So I'll go to the next slide, just to quickly go through and talk about, what global industry of higher education is all about. We've got faculty traveling to conferences outside the United States, students traveling abroad, numerous study abroad programs that we know have been canceled for this spring, faculty, students, and staff traveling abroad for conferences, for vacations during spring break, foreign faculty coming to our campuses for visiting teaching positions and research positions, and then collaborative research relationships throughout the world that U.S. faculty have with China and with all over the world. And the next slide, in our campuses, there's a lot of close quarters. We've got lecture halls, large lecture halls, auditoriums for concerts, obviously residence halls, dining halls, sporting events, tournaments. We're coming into March. Whatever the NCAA is going to do about March Madness, I don't know. Yeah. So next slide, I wanted to describe what universities and colleges are doing. I mean, I think everyone has a website about coronavirus. All weekend I was looking at basically coming up with different schools and just Googling such and such a school coronavirus, and there's lots of web pages out there. There are direct links to the CDC, which, as Dr. Falsey pointed out, that's the best, most up-to-date information. And colleges and universities are regularly communicating with their constituents. I was looking at one website, Barnard College, I think, probably had a communication going out 6 times in the last 2 weeks. So it's constantly being updated. Many colleges are prohibiting university-sponsored travel to CDC level 3 and level 4 countries. Now, obviously, university-sponsored travel, the university can say we're not going to pay for it. But if people are traveling on their own, I mean, there's really no way that a university or college can stop that. Over the past 5 days, study abroad programs have been canceled in high-risk countries. And I wanted to point out, as of last night, I didn't get to put this in the slides, but the CDC issued a bulletin advising higher education institutions that they should cancel programs in Japan, Italy, and China, and South Korea. Now, the word should is an important word to think about. What the CDC is doing with that directive is really raising the liability for colleges and universities if you don't cancel it. But my concern is many of these programs are sponsored by third-party contractors. And for example, if you have a spring program, a mini study trip to Europe, and you decide to cancel it, I've looked at a couple of contracts in the past 2 days, and the contracts basically refer to you can only get your money back if it's a government-restricted cancellation. You know, basically, because if the CDC were to say Italy or France is level 4 or level 5 and it has to be canceled, then you might get your money back. But if colleges and universities are opting to cancel these programs, you might not get your money back, and students may not get their money back. So these are really critical issues that you have to think about. Student housing is being provided. NYU, for example, has on their webpage that if you're coming back from a country like Italy or South Korea, they are offering separate residence halls for these students to self-isolate, even though that's not been mandated by the Department of Health. So they are
not specific regions, the whole country?
The whole country, yes. Now, there's, as I said, there's been a lot of communication to students about public health recommendations and travel. Next slide. I wanted to specifically point out, actually, so these 5 universities and colleges, I picked 3 of them because I worked at all 3 of them in my career. And several of them are in New York. Rutgers is in New Jersey, and of course, University of California. And I'll go through I gave you the websites, but I wanted to describe a little bit about what each institution is doing. Barnard College, for example, has on their website that if you are returning from a country that is a level 3 or level 4, they're asking staff, faculty, and students to please register. So they actually have a link on the website. Provide us with information, confidential information here. So you link to it, and it has you fill out where you've been, and then it has a where you live and what classes you have. So it's now it's voluntary. I mean, they can't they're not forcing people to fill it out, and it would be hard to enforce if they were actually mandating that people fill it out. So they're collecting this information, and obviously it's for public health purposes, and I think it's a very good idea to do that kind of thing. Cornell University, just last night, they issued a new policy. So it's dated March 2nd, 2020, and they're requiring students, faculty, and staff who are returning from CDC level 3 affected areas, so including China, South Korea, Italy, Iran, as well as Japan, to quarantine at home. So they're not allowing these students on campus. And I think they are providing for separate residence hall situations if students cannot go home. So that is on their web page. And
Monica, do we know if they're doing anything about remote learning for those students?
Yeah, they are doing, and that's information that's included on the web page, that they are providing remote learning. And Rutgers University, sorry, I just skipped one. New York University, I mentioned it earlier. They do have separate residence halls, but Rutgers University and New York University and Cornell and University of California all have university health systems. So the information on these websites is really, I think it's really good, because it's not that Barnard is not good, but it's filled with medical information directly from their health systems. So Rutgers actually has a waiver for students to sign if they refuse to come home from a program in Italy. So I wanted to point that out. If you go to that web link, you can find the waiver, and it's titled "Informed Consent and Release of Liability for Travel Abroad to High-Risk Countries and Regions." And I'll just read a few sentences from it. I, Monica Barrett, acknowledge that I have been informed that there are risks involved in choosing to travel to or remain in Italy in spite of a Rutgers University travel restriction. I acknowledge that I received, read, and understand the Rutgers travel warning dated February 29th, 2020 regarding travel to and within Italy. Despite the Rutgers travel warning, I have decided to pursue my plans to travel or stay abroad as a registered Rutgers student. So they're asking students to sign that, and then if you drop down a little further, it says, I expressly intend that this release binds me if I am alive and my estate, and if I am deceased or otherwise incapacitated. So I mean, I think 20-year-old students might sign this, but their parents will have a heart attack.
Let me add that courts don't like release language any better than you would want your children signing this document. The operative words in any one of these is assumption of risk. I assume the risk. Courts will respect that.
Yeah, I think the probably the goal here is just to scare people. I mean, whether or not this is going to be effective in court, that's another question. But I think it's a good tool to have people, especially traditional age undergraduates, understand if you're going to stay in Italy and travel, then you should be aware that these are concerns. Now, finally, I wanted to point out, I think the best website is the University of California website, and I was showing it around this morning here because I think I always look to California law because they're always the first to do, and maybe New York is the second to be having progressive laws in place, progressive civil rights laws. And the University of California system has a ton of lawyers who probably stay up all night writing these things. But the guidance is incredible. It goes through questions and answers related to all members of the campus community, questions, answers related to employees, questions, answers related to students, questions, answers related to privacy and duty to report. It's got a drop down for the questions and the answers, and even though it's California law, I mean, it's good to just look at it and for informing yourselves, and if you have to go to meetings about the current coronavirus this afternoon, which I think Antoinette, you probably do, you can look at this.
So any of them have an actual response plan that we might look to as we form our own?
Yeah, they do have the University of California system page has a response plan, and and actually it has a different plan for each institution in the California system, and I think University of California Davis, which is where there have been outbreaks of confirmed cases, they have a definite response plan, so that's worth taking a look at. So next slide, I wanted to go through quickly the impact on higher education. Now, I read this in Science Magazine over the weekend, and it had a list of the number of conferences that have been canceled this spring. And I want to point this out because at these conferences, graduate students have job interviews, and academics work on collaborations. That's where that's maybe the only place they meet face to face with people they're collaborating with. And tenure track faculty meet up with their collaborators at these conferences. So this this slide and the next one just show the science conferences that have been canceled. And if you go to the next slide as well, and it's pretty dramatic. And I wasn't able to find a list of humanities conferences because maybe they're just not in this time period of the academic year. But it's a very serious impact on the workings of higher education institutions. And then one example I deleted. Actually, this just shows how it's changing constantly. One conference was scheduled to be held in Beijing, but it had been moved to Rome. And and so I deleted it right away because I thought that's not gonna, I mean, they're gonna move it somewhere else or cancel it. And then the next slide, I'll show you how it transitions into the last one, EDUCAUSE. That's a lot of administrators, higher education administrators attend that conference. That conference was canceled Sunday, March 1st. It started it was scheduled to start March 2nd, and half the people had already arrived. So that's going to be quite a nightmare about refunds, and so there are a lot of these cancellations that are occurring. The troubling issue is that if you are planning a conference or if you are planning a gala for, a fundraising gala for your private institution, do you cancel it because your guests are nervous about coming, but then the third party contract may provide, we will only refund your money if there is a government order that you cannot hold an event. And that's going on right now in Paris. You cannot hold events that have more than 5,000 people. And that one conference, the American Physical Society conference in Denver, had 10,000 people. But if it were in Paris, you might be able to get your money back, but maybe not in Denver if it was canceled. So go to the next slide, please. So I wanted to go through these lists of tips, and thanks to my colleague Gail Norris, who just joined Bond after she was general counsel at the University of Rochester. And she came up with these tips for higher education institutions. And when I was looking through the list of items, I was recalling Hurricane Sandy back in 2012, and that's when I was working at Rutgers, and Rutgers, because the Raritan River runs right by Rutgers, one of the campuses, and half the campus was flooded, and the university shut down. And at the time, we had just gotten a new president who was shocked that we didn't have an emergency management business disruption plan in place. Cell phones were gone for a couple of days during Hurricane Sandy. So if you started working on business disruption plans after Hurricane Sandy and put them aside and didn't finish them, you might want to pull them out again. So again, to ratchet up your anxiety level, does your institution have emergency management and communications plan to cover pandemics, and do you know what it provides? These are questions, I'll leave you with. I'm not going to ask you if you. When should your institution impose travel restrictions, and how would such restrictions be scoped and monitored? This is where, I think if you're going to require faculty, students, and staff to stay at home for 2 weeks after they've traveled to Italy, if they arrive back after spring break, how are you going to enforce that? Are you going to ask people to prove that they weren't in Italy when they traveled? They just went to England. If somebody doesn't want to stay home and somebody else tells you they were in Italy, what do you do? So these are issues where you might have a policy in place and you might mandate that they have to stay home for 14 days, but some people may not tell you where they've been. So do your HR policies and practices allow your organization to follow public health recommendations regarding work restrictions to contain the spread? Now, operative word there is recommendations. So the CDC is saying should do this, should. So that's a recommendation, it's not a mandate. So so make sure your HR policies for the next crisis, if not now, are updated to show this kind of situation and how you would address it. Next slide, please. So should your workplace become compromised due to the virus, how would decisions regarding work be made? So do you have a point person who is the go-to person who knows that how to distribute the work? Maybe you need to find out what employees are working on and what's time sensitive. Do you have a business continuity program? I talked about that already. And what will you do if a student or faculty member or other employee wish to travel abroad to an outbreak area for personal reasons? What if a foreign student's parent is very ill, not with coronavirus, but with something else, and they want to go back and travel? You have to think about those cases that will come up. And how will you monitor personal visitors who come to the campus, and how can you identify them? I think the Barnard practice is good. Do you want to have a registration program for visitors for the next month, just to know who's coming to your campus? Next slide. I think Teresa, she talked about this in the discrimination section. How do you respond to fears, rumors, and concerns about the pandemic? A lot of our K through 12 schools are getting calls from parents where the parents say, I know that child's family was in Italy skiing and they just arrived back. Why is that child in school? How do you handle that situation? And then I think this next one, if you must shut down temporarily, how will you deal with student grades, especially for graduating seniors? So what do you do? This reminds me of post 9/11 when there was a military call up for those in the service, where a lot of states had laws in place that required universities to give the grade that the student had earned up to the date that they had to go into service in the military. Will we be in that situation? That might occur. And then finally, we talked about this. Do you have online capabilities for transitioning live courses to the online format? Is that possible for students that you're asking to stay home? And this seems like I'm saying do not panic, even though I cause you all to panic. But do not panic and do not discriminate. And then the last slide, just quickly, issues for public school districts. Now, we have a lot of clients who are public school districts. We also have a lot of clients that are private independent schools. Public schools operate under constitutional standards, and there is a requirement that public schools provide services to students. so that the public schools have to defer to the Department of Health and State Education Department. And I put in here links to the state ed letters to parents and letters to public schools. And it highlights the importance of not discriminating against students, and you cannot refuse to allow a student who is asymptomatic from coming to public school. And the last thing on the slide, if these are all cases back, if you look at all the years are the late 80s, and some of you might guess that all these cases have to do with HIV/AIDS and the prohibition against discriminating against students based on perceived disability. So that's it, and I hope I raised the anxiety level, but not too much. And I think we have time. No, we don't have time.
Monica, might I add something?
Yes.
As we've been conducting this seminar, we've had a question on our internal labor discussion board, because one of the post-secondary institutions we represent has a union president who has said, in words or substance, "You can't make our faculty teach remotely if you shut this place down." My response to that would be something you can't print in a family newspaper, but it is a good reason, if you're contemplating that as a possibility, to take a look at the management rights clause in your collective bargaining agreement so that you can formally formulate your plans with your powers in mind.
Great. Thank you. All right, thank you, everybody.